Rehabilitation technique in clinical condition. Dr. Saurav Shandilya is going to take this webinar from MyDHab Academy. So everybody, please update your correct name, because your some name is not matching with our database. So which you have given during the time of booking your seats. So it is humble request everybody to write the same name. Otherwise, I will yes, unfriend this. So now, Dr. Saurabh. Dr. Gaurav Maji came, and Dr. Sandeep Negi. These two is, I can see absent name is there. Other are present. Dr. M. Sankar, can you change your name?
Apologize for my system issues. It was quite unpredictable, because even yesterday night I have done some of the conference. So today we are going to see the cardiopulmonary conditions, the advanced techniques. But before that, I would like to tell you that we are going to talk something about the functional anatomy. We are going to talk something about the basic concept, and anyway, you know the basic concept. So we are going to talk more about the advanced concept of functional residual capacity. We are going to talk about equal point pressure. We are going to talk about functional anatomy, PT assessment. What is your goal and how do you do that? What is the mechanics and mathematics behind our goal? And how do we go about the exercise prescription along with the techniques? And how do you choose every technique wherever you feel that you are going to use? So I think you all have joined. I was only delayed, so I'm starting now. So the what should be your what is the introduction and the goals you need to decide? Means when we use these cardiorespiratory physiotherapy techniques, in general, we are using these techniques in general for some of the conditions like acute lung disease, of course, chronic lung disease, even the advanced neuromuscular diseases, major surgeries, cardiothoracic, abdominal, like these kind of surgeries. So we have to see which surgery we are using, what is the major problem in those surgeries. Again, we are using for the patients in, of course, in ICU, and then we're using for the patients having a difficulty in increasing their normal day-to-day activity. So this is how we are, these are all the zones where we are using our techniques, right? So when we talk about the technique, we should always remember one thing: what all our aims are. Okay, so our aim is, our aim is to manage breathlessness symptom control. Our aim is to go for the airway clearance. Our aim is to have better mobility, improvement, even the maintenance, the kind of neuromuscular condition where it is a kind of progressive disease. You can't think about the improvement much, but you can think about always the better maintenance. Then we talk about like ideal improvement in most of the neuromuscular conditions, ideal improvement. So these all are our aims. But before that, like deciding the goal, we are going along with these aims. Like how do you decide these goals? So main problem, what do you see? This depend upon that you decide your goal. Well, so main problem is cardiorespiratory disorders. Like what kind of main problem you see? You see reduced lung expansion, you see impaired airway clearance, you see increased work of breathing. That is something we will be seeing. Why our work of breathing should be less. Now we have another problem like impaired exercise tolerance, isn't it? That is the major problem you face every day in your OPD. Then inability to perform activities of daily life. That is something, these all are points where actually these all problems where actually you make your goal. Okay, so think about your problem and then you make the goal. Next, divide your goal into two parts. Okay, like short-term goals as well as the long-term goal. So short-term goal is something where you expend less aerated lungs. You see, it's a kind of acute problems where you get, or subacute problem, right? To clear secretions. That is the most important. To reduce the work of breathing, in case of, you see, acute attack of asthma, what happened, right? So next, the long-term goals. Long-term goals is something to educate patient, to improve exercise tolerance, to improve ADLs. Okay, so these all are the to improve, these all are the long-term goals. So depending upon your, what do you want, you need to select what is your problem. Okay, what is the patient, what is the problem your patient is facing. Next, let us talk about overview first. Then we'll be talking about what is the functional residual capacity, equal point of pressure, as we will be progressing today in our, this one, though I'm having some of the technical issues, but I'll try to clear most of you what are we going to do about this. So, in general, we talk about lung expansion therapy, but what is lung expansion therapy? Why it is needed? Whatever is a lung expansion therapy, we are going to see in another 5 or 10 minutes, but lung expansion therapy in general, what do you know? These are given to the patients with less lung volumes, or maybe they have lost the lung volumes because of their disease. And it depends upon what is the level of consciousness. You cannot expect the same from the somebody having into coma and somebody having into the subconscious, and then somebody is quite conscious and he is having a COPD kind of stuff, right? So it includes a lot of things. What? Positional breathing, positioning. The most important is positioning, right? I think my video everybody is able to see. My video is everybody able to see?
So your camera is switch on, your mobile camera.
My laptop camera is switched on.
Yeah.
Is it okay, sir?
That's fine, but mobile also if you can on.
Okay, then this presentation will be little. Anyway, I'll try that. No problem.
Yeah. Okay.
I'll try that. Sure. Fine. So I was talking about our presentation. Yeah. So the thing is now. So now, yeah. So in general, I was talking about positioning. Positioning is so important. Okay. So we have a positioning. We have a different kind of breathing techniques. Majority of you have learned right from your second year of exercise therapy, and after that we go for the mechanical aids like CPAP, BiPAP, these kind of apparatus, right? Why do we want that? You'll see that. Majority of you know about CPAP, no doubt about it. But how do you differentiate from the BiPAP? Why do we need that? Which all conditions we need it? When do we need it? So these all things we can, over the period of another hours, we'll be seeing that. Now, next we will be talking about airway clearance techniques. What is this? This is basically the most, traditional methods like percussion, vibration, shaking, ACBT, autogenic drainage, mechanical aids like flutter, a cappella, PEP mask, etc. Right? Then you come to the, what do we do for to reduce the work of breathing? We use positioning, relaxation, we use breathing techniques, and many mechanical aids. Right? Another problem, what do you see in this case? I told you, we have a problem called the reduced physical activity. So what do you do for that? You do a lot of conditioning exercises, isn't it? You do you actually design something called the cardiac rehabilitation, right? So these all things you do for. And then next is therapeutic interventions for common abnormalities. That is very, very common. Tachycardia, hypertension, orthostatic hypotension, arrhythmia. Say for example, I'm just giving you an example because I want you to understand this clinically. Very clear concept. Concept is a person had a subdural hematoma. I mean, he's a case of head injury. He suffered head injury. Then he was in coma for about a month. Then he got little bit arousal and the trauma was on his temporal lobe. Well, and it was a concussion injury. I hope that you understand well concussion injury. So after this craniotomy and everything, now the person who was on ventilator, slowly he was shifted, you know what we see, the weaning of the ventilator, very important concept. So he was shifted upon without ventilator. I mean, he was shifted on the, then what we say, the normal oxygen, okay, hyperbaric oxygen in that case. And now he's shifted on the CPAP. Why it is like this? Because we want CPAP to clear his, to have his windpipe all the time open. So it works like a splint, the same splint. Suppose I'm wearing the wrist splint, right? What does it do? Suppose I'm having a wrist drop. What does it do? It actually prevents the wrist drop. Isn't it true? Yeah. So in this same case, here CPAP makes your windpipe very, very open. Okay. So these are all things very important to understand for physio. What happened during sleep, even we have a tendency of closing down our windpipe. But according to our, like a swallowing capacity, everything that keeps normally open. But in these cases, when they are into the sleep, there are chances they will not be able to bring pipe because of the choking of this. So we use the CPAP. So for a physio, to understand CPAP and when to do CPAP, how much to wean off, how many hours to be weaned off, these all things are very, very important. So for that, what do? We have a controlled mobilization, work simplification, for reduction of work of breathing. That is something that debilitating during the course of disease. Well, so next is we'll be talking about lung expansion therapy. So lung expansion therapy. Look, lung expansion therapy, be very clear. Today we are talking about lung expansion therapy. Then you know very well what it is, but how do we have to plan it? That you have to be very, very clear, which all conditions we plan. So we have a group of techniques used to expand a collapsed lung. Both in conscious and unconscious patients are generally termed as lung expansion therapy. Well, now, what all conditions we use? The most important is atelectasis. You know how to differentiate the atelectasis lung? I mean, by seeing the X-ray. Anyone has any experience about it? If you have any experience, you can answer in the chat box also. Okay, so this is how. Yeah, so next is a consolidation. Okay, well, no problem. Lalit, we are coming on this. I'll be giving you a comparison of X-ray and the normal, this one, like then you can understand how it goes. And then pleural effusion, very, very important. See, we'll be talking about pleura, interpleural pressure, everything, but first to understand which all condition it is needed. Pneumothorax, very, very important condition. Then it comes to abdominal and cardiac surgeries. In that surgeries, we need lung expansion therapy. Let me tell you one thing. Is there any upper abdominal surgeries in general, the patients have difficulty in breathing in general because of the diaphragm get into the trouble. Okay, but the same problem, if it happens with the lower abdominal surgery like appendicitis and all, breathing generally is not a concern unless the patient is obese and having a pre-morbid or like a precondition, something like a COPD or something. Breathing won't be issue. Where there, in that case, the leg and the DVT becomes a bigger issue. Okay, so After that, in general, what is that? Restrictive lung disease. Today we'll have a beautiful graphical representation. How do we differentiate the obstructive, restrictive, and what is the difference between COPD and asthma? Tomorrow when doctor asks you, how do you differentiate between COPD and asthma? You should be able to tell pharmacologically, mechanically, and being a, what we say, the cardio rehabilitation wise. Sorry, pulmonary rehabilitation wise. Now next is, look, I'm showing you this X-ray. Okay, in this X-ray you can see, yeah, you can see in this X-ray. Okay, what is the difference? I'll be taking you previous slide to see. Okay, generally clinical signs of atelectasis is like how we generally following the surgery, abdominal or thoracic surgery, or history of chronic lung disease, or cigarette smokers since quite number of years, tachypnea, tachycardia. So these all are the signs we see, you know, signs. I'm not talking about symptoms, I'm talking about signs. So when you do the what we say, that auscultation, you find bronchial and breath sounds, find an early inspiratory crackles, right? So in this case, what is happening? You see displacement of inner lobular fissure toward the affected zone. You can see this. Now you come, crowding of bronchopulmonary vessels in the affected zone. Okay, so these all are the signs. The moment you see X-ray, you will say that this person has got atelectasis. Elevation of diaphragm in affected side. You see, you could see this. Anyway, this X-ray will come to your manual also. I'm sending the soft copy manual, so you'll be able to see easily. Shift of trachea toward the affected side. You can see the shifting of trachea. We'll be talking about today why pneumectomy we have a problem of compliance issue. I'm sure many of you are getting confused with the compliance. Today onward, you will have no confusion in compliance. Shift of mediastinum and hilum toward the affected side. You can see mediastinum and hilum. What is the condition? It is shifting toward the affected side. And then narrowing of space between the ribs and the area of atelectasis. Very, very common. Very, very common. Okay. Next, compensatory hyperinflation of opposite lung. Of course, nature, structure, and function are complementary to each other. So wherever there is a loss of structure, function will be taken over by the compensatory organ. So that you know very well with your pathology. So this is the X-ray of an atelectasis film, case. This film, you can see these all changes. So once you see this case, you'll be able to see this. Anyway, we are having a very beautiful upcoming program on X-ray, MRI, and CT for physiotherapists. How you can read the film. So that is, I think, the month end. This month end, it is there by a famous radiologist. So if you want to join, you can talk to our team. There you'll be able to find these things even more clear. So how do you differentiate the TB? How do you differentiate the pneumonia? So today I will be letting you know if there is a pneumectomy, why there is a compensatory fluid problem, why there is a compliance issue. So today onward, I'm telling you all 13, 14, whoever have joined, compliance will not be a problem, because whenever we talk about compliance, people get confused. Oh, compliance means something like elasticity, lobular. Oh my God, forget about it. We have to do our breathing problem issues, solve to the patient, that's finished. No, once you learn about compliance, I'm telling you, your pulmonary rehabilitation, making up of that will be wonderful, and it will be too great to understand how to not just design the protocol, how to take it for the further follow-up. Okay. After this film, let us talk about what all the mechanism involved into this, because I told you, unless you know the mechanics and mathematics of the pulmonary system, you will not be able to understand this really well. There are generally 3 mechanisms involved. Just understand this. If you understand this, next our technique, whatever I'll be showing through the video, I'm telling you, this will be too easy to understand. Just understand this. First is increasing transpulmonary pressure gradient. What is transpulmonary pressure? Okay, anyway, we are coming on that. Next is improving collateral ventilation. And third is physiology of interdependence. You see, all these 3 may look little bit, like advanced concept, but I'm telling you, this is the concept. If you remember your first year, it's becoming very easy. Transpulmonary gradient is nothing. It's a difference between intrapulmonary pressure and intrapleural pressure. You know very well intrapulmonary pressure, and you know very well intrapleural pressure. Intrapulmonary pressure remains negative, positive. It goes from positive to 0. But intrapleural pressure, when we talk about, it always remains in negative side. Okay. So difference of that is TPP gradient. If you have any breathing technique, whatever you know or you learn from the different lectures, digital, physical, bio professor, wherever, if you know how to increase the TPP gradient, your things are done. Your lung expression will work. Okay. So just think, intrapleural pressure, as I told you, it always remains negative. Why it is like this? Even during the inspiration as well as the expiration, why it is like this? First is because of the elastic recoiling capacity of lung tissues, which is pulling the visceral pleura toward itself, inwards, and chest wall has a different thing. Chest wall has a tendency to expand outwards, pulling parietal pleura, which is adherent to the chest wall. Now, I hope it is clear. Okay, but how does that work? Look, many people get confused between chest wall pressure and pleural pressure. I don't want you to confuse. I said about visceral pleura and parietal pleura. There is a difference between that. You can say the intrapleural pressure, but there is no question that you should get confused between the chest wall pressure and pleural pressure. I am being very clear. Many places people get confused between chest wall pressure and pleural pressure. Compliance of both are different. Both are different when it works on that. So don't get confused. Just try to be very clear about it. Improving collateral ventilation. I'll be coming to the picture, then you'll be very clear about it. What happened? It is not just a single hole to the alveoli, right? It is having a like different kind of orifice. So there are 3 channels basically. What we say the collateral channel. First is the channel of Martin. What we say interbronchial. So 2 bronchials will be connected with that. Then will be the channel of Lambert. Okay. So that we say bronchoalveolar. Okay, bronchial to alveoli. Then there is something called pores of Kohn, intraalveolar. Okay, so then comes our physiology of interdependence. Okay, don't get bored. It is very simple. Okay, I'm coming to the 4th picture, then you'll be able to see. See, this is the physiology of interdependence. You can see my pointer here is the normal breathing. Okay, so when this is the normal breathing going on, all the alveoli getting the air and all filling sac, this one, all the sac is filling, and then you know that beneath deep sitting sac also getting a negative pressure, no doubt about it. Now what happened? Airway collapse. So once the airway collapse, the deep seated alveoli are more collapsed, right? But in case of large volume inspiration, what do? We have a pressure going outward, right? So because of this pressure, deep-seated alveoli get expand. That is how the concept of physiology of interdependence. I want you to learn this very clearly because in your techniques, these are going to matter. See, I was talking about this one. Yeah, see, 2 alveoli together, connected together by pores of Kohn. Then 1 alveoli connected to the bronchiole with the canal, the channels of Lambert. Then there is something called channels of Martin, which is connecting the 2 bronchioles. Okay. I have a question for you that I want answer after maybe 20 minutes. Question is, why do we say bronchial asthma? Why don't we say bronchiolar asthma? The question is very simple to you. Why do we say bronchial asthma? Why don't we say bronchiolar asthma? Okay. Think about this question. I'll be coming back to you when I ask. You should be able to tell whatever you know, you just let me know. Okay. So depending upon that, I'll let you know how things are designed. Okay. So in this, as I told you, we have a different techniques like control mobilization. We have a different positioning. We have a different kind of breathing exercise. We have a PNF into the breathing. You know, PNF for respiration, one of the beautiful technique, especially for the unconscious patients. Incentive spirometry, IPPB, what we say intermittent positive pressure breathing. Then we have a positive pressure therapy. I'm telling you today, positive pressure therapy, there are a lot of apparatus like a capella, flutter, a lot of things are there. But today I'll be telling you one very good technique. In that you can take a bottle and you can actually make by yourself. Continuous positive airway pressure. Okay, so CPAP as I was talking to you, and then BiPAP. Next is, how do you administer this technique? Is there any kind of rule? Yes, we have a rule. Rule is, like every technique, you can't put everywhere. If patient is unconscious, PNF respiration. If patient is not alert, IPPB. If patient having a problem with excess secretion, what are you going to do? PEP, positive expression technique. Then if patient is conscious and cooperative, incentive spirometry, majority of you are using. Okay, you can't use for the unconscious patient, or you can't use for somebody who is having a like a bedridden condition after the neuromuscular disorder, right? So now if patient is still not resolved, then we are using the intermittent CPAP technique, right? Next is the bronchial hygiene therapy. What we say, the chest clearance method, right? In this, bronchial hygiene therapy involves the use of non-invasive airway clearance techniques where the physical means of facilitating removal, the removal of trachea, bronchial phlegm through the external or internal manipulation of airflow and evacuation of phlegm via coughing. So you have a different techniques here, like a percussion, vibration, shaking. You have a technique, autogenic drainage, you have a postural drainage. So you have a lot of techniques, right? So before getting into those techniques, let us understand two things. Okay, what is our defense mechanism? So I was telling my CEO today. So if this class student or any professional attend, it will be very good for them to restart their OPD and practice. Why? Because they'll have a revision of this. So let us talk about second year. So normal defense mechanism, whatever defense mechanism we have, let us talk about this. The main defense mechanism is what? Sneeze reflex. Anything getting into our nose, we try to sneeze, right? Now, let me tell you, the sneeze reflex says that it is a kind of protective reflex, right? So you have a cough reflex, you have a mucociliary escalator, right? So if antigen passes these layers, then non-specific defense mechanism counter it by phagocytosis through neutrophils and macrophages and complement activation. Okay, so these are again the getting the first line of defense, second line of defense, third line of defense. So a specific defense mechanism is what is resulting from the specific immunological reactions to a certain antigen. Okay, say for example, presently running the COVID. Okay, so COVID will go inside. COVID will produce like antibody has to be produced like a for the COVID, right? Okay, I'll be talking little detail just a minute, and then majority of say for example I got rhinovirus. Okay, so I have a more IgE level. Why? Because eosine has increased. What we say, the eosinophilia, is it? Eosinophilia. Then other secretory like IgA. There are 5 kinds of mostly antibodies like IgG, IgA, IgM, IgD, and IgE. So next, what happened? These are so specific. So whatever antigens get into the body, they have antibodies preparing for that. So it's a kind of World War, antigen and antibody. So you would have heard many kids after vaccination, they feel they have fever, right? Why it is a fever? Or why it is a kind of lack of hunger, everything? Why? Because live virulence have been given so that we want specific to be given so that the antibodies to be produced. So it's the antigen antibody fight. Okay, so that is giving the symptoms for 3-4 days. So over the period of these things, now it is into the memory. So we say memory molecules. Tomorrow, if the TB comes inside, if I'm having a TB vaccination, it will fight with that. Clear about it? So that is how our antibodies and vaccination part work. But apart from that, let me talk about this. The beautiful thing I spoke just now, something called a mucociliary escalator. How does that work? How does that work? Anybody has any idea about mucociliary clearance mechanism? How does that work? Okay. Or have they read about mucociliary reflex or something? Anybody has any idea? Okay, no problem. It is a kind of cilia. Okay, either forward or backward. This is the stroke. Okay, so something coming in between, a stroke will be like this to take it out. So there is a ciliated epithelial cells normally move the particular mucus via in a coordinated wave of ciliary action toward the trachea and larynx, where the excess secretion can be swallowed or expectorated. Simple, very, very simple. Now come to the COVID. Why do we say this immunity is very, very important? Okay. Why do we say COVID affects more to the diabetics or hypertensive people or having any kind of kidney disorder. Why? Have you ever thought it? Very good, Varalakshmi. To and fro movement, yes. Did you ever thought about it? No, right. So we have something called the mucous immunity, what I'm talking. If a person is on the diabetic treatment, okay, he's taking medication or he's taking antihypertensives more in amount, what happens, you know, this mucosa reduced, it get eroded, okay. So any infection will be, or any what we say antigen will be easily traveling for them. Reason behind that, we have always issues with the person having a diabetes and hypertension. You got my point? So these all are the small points. You must understand this, because this is how the science becomes interesting. So in general, abnormal clearance, how does it work? Normally, it's a vicious circle. I'll let you know which level you break what. But first understand, antigen went inside, mucus plugging. Okay, then it can create the lung infection. Okay, but before that, where does it start? It start again the normal infection because of mucus production and then mucus retention, which create the lung damage. Okay, so then it happens what? Mucus plugging, then again the infection. So it's a vicious circle. It keeps going. How do you how do you break this? You have a different things to break, like nutrition, okay, anti-inflammatory drugs, you have a bronchodilators, you have mucolytics, you have antibiotics, you have airway clearance techniques. So these all things at different level we use. Suppose somebody has a suppose somebody has a like pneumonia, along the nutrition will not work, right? So that is how I'm saying you, different level we have to think differently. So techniques of airway clearance are in traditionally we know about coughing, huffing, turning, postural drainage, percussion, vibration, shaking, active mobilization. Relatively newer techniques, you have something like autogenic drainage, SEBT, FET, majority of you use. Mechanical devices, there are many high frequency, we have a high frequency ventilator, we have a PEP apparatus, positive and expiratory pressure apparatus, we have a Mackin X sufflator, and then we have a flutter, we have a capella, we have a cornet, we have a frequencer, we have intrapulmonary percussive ventilator. So these all are the devices you would have heard or you would have read in the right from the textbook to advanced book. You can read all these devices, you can read, and then you can use in your hospital depending upon their availability, but try to learn what is the principles they are using and what is the physics behind every instrument. Because you know, two things will be very clear for any device, for any uses, for physio. First is, what is the biophysical principles? Second is, how do you do apply? Means, what is bio application? I mean to say, ultrasound is a mechanical device. Do you know about it? Ultrasound is a mechanical device. Do you know about it? Ultrasound is a mechanical device which actually works. It's not needed. Yeah. So why it is a mechanical device? Have you ever thought? Why it is a mechanical device? Anybody? In chat box? Okay. Ultrasound is a mechanical device because it uses the piezoelectric effect. Okay. It converts the electricity into the movement, isn't it? The piezoelectric crystal, which creates the ultrasound wave, right? So it is what we say again. These kind of apparatus, we need to differentiate what it is and how do we use it. Suppose tomorrow you see CPAP. So what is the biophysical? Wonderful. What is the biophysical principles behind CPAP? And what is the application, right? So every device, whatever you see for physio uses, being a physio, learn about two things: biophysical principles, and second thing is bio application. Now, any kind of chest clearance technique or bronchial hygienic technique, we administer according to the age. Okay, conventional chest physiotherapy we use for almost all age, no problem. But if it is a 0 to 1 year, use CPT. You go for the 1 to 2 years, blowing games like pinwheels, blowing this, blowing balloons, something like that. If it is a 2 to 3 years, HFCC, high frequency. 4 years, coughing and huffing. If it is 4 years and more, PP, flutter, a cappella. If it is 5+ year kids, you can go for SEBT and exercises. If it is, say for example, more than 10 years or 8 years or 10 years, IPPV you can administer. But autogenic drainage for the person before 12 years is not permitted. So keep in the mind, according to age, we go for the chest clearance technique. So in the class today, you are getting clear about your concept, which technique to apply where. Okay, next is the work of breathing. This concept is particularly very, very important. Why? Because work of breathing, I have a mathematical formula. I will discuss that later. First, you learn about the biological formula. So work of breathing is what? It is amount of pressure generated to move a certain volume of what we say, gas. Okay. So in general, what is that? What is the work of breathing? It is general the work done during the inspiration to overcome the resistive, elastic, and inertial force of the airflow, lungs, and wall. Suppose I am a normal person, I am breathing. Against what I breathe? Against what I did? Against the elastic capacity of my lung, right? I did according to the chest wall. I expanded the chest wall, right? I did the airway resistance. Suppose I'm having some cough, I have resisted that too, right? So this is called the work of breathing. So it is actually what? Any work is equal to what? Generally, work is equal to what? How do you calculate it? Force into displacement, right? Physics. Now come to the biophysics. Go to the super physics. Force into the distance into the cos theta, what we say, means it's something like a force into displacement. Now come to the biology. It is a work of breathing is equal to what? Product of transpulmonary pressure gradient into tidal volume. Simple. So your transpulmonary pressure gradient, being a normal person today, I'm having a better transpulmonary pressure gradient, right? Suppose I'm having a pressure gradient of 5 and or maybe 4. Okay, 4. Let us take 4. And my tidal volume is about 500. So 500 into 4 is 2000. Okay, work of breathing is 2000. Okay. Now, work of breathing, how much it consumes the oxygen and energy? ATP. 4%, up to 4%. Oxygen consumption at rest it is needed. But when you are walking, running, then it becomes more. So work of breathing increases with the breathlessness, because transpulmonary pressure gradient keeping at same level, you need more tidal volume to compensate your physical activity. So you have a what we say modus operandi. Suppose I'm a person, I came to your clinic for pulmonary rehabilitation. You'll be checking the work of breathing for sure. Work of breathing, either you to decrease work of breathing, you can have some strategy. But I'll tell you, meanwhile, since you're a clinician or maybe the student, I'm not sure, I haven't seen your profile. So even though you're the student, apply your mind, or you can take into the like a kind of research project in your college in 3rd year or final year. What happened? Here you play 2 age strategy. One age when you are making the person to have a like a wonderful breathing. In that case, you can decrease his energy demand. Suppose the person with the spinal muscular atrophy, say for example a kid with spinal muscular atrophy, now he's about 10 years, say for example. So in that case, what is happening? You will be thinking of decreasing the energy demand. So you apply certain strategy to decrease the energy demand. What could be that? That could be handling, that could be sleep and rest, that could be stress reduction, positioning, breathing re-education, mechanical assistance, exercise training, inspiratory muscle training. Look, these all strategies very easy. If you understand handling, you should ask this kid, because she's on ventilator, she's on CPAP. You should ask whether you want today, say for example, pizza or you want burger. I gave example of pizza and burger. These kids are not supposed to have. So Close-ended question. What is the benefit of close-ended question? Answer will come close-ended. Okay, I'll ask you one thing. What breakfast you want to have today? Or say, for example, Sunday. So what lunch you want to have today? Then you'll be thinking, oh, right from the veg to non-veg, you have a long list of, the food materials, right? So, but if I ask you, dear participant, suppose we are having a physical workshop that we are going to have any time now, once the government allows. So in that case, if I ask you, you like to have pulao or you like to have paratha? Then you will be very easy and confined to say, sir, let us have paratha. Okay, so very clear, right? So it actually decreases their stress level, it decreases their, what we say, talking, right? Because talking takes a lot of energy. Then sleep and rest, very important. Sleeping is important because it decreases the breathlessness. Clear? Positioning. I'll ask you, how do you position the acute asthma patient? I'm just asking. Anybody has any answer? Then just can tell in the chat box, because at 10 o'clock we'll go for even higher concept. How do we do that? Okay, fine. Let me tell only. Nothing. Even though supine line, just place a pillow. Well, possible. Half-lying position, possible. No problem. But always you keep a pillow roll or something below the knee, so that knee is little bit in flexion. Okay. It reduces the, what does it do? If you bend the knee, what does it do? It actually supports the diaphragm, isn't it? With the visceral, it increases the intra-abdominal pressure, which gives the push to the diaphragm. So it is a kind of precursor for the breathing in, right? Correct? So these kind of things we do. I gave you an example. Now you can apply your mind and can think about example for other patient. Okay. Suppose a patient for pneumectomy. Okay, anyway, we'll come. Like, how do we differentiate the pneumectomy now? Mechanical assistance, very important. As I told you, CPAP. You check the saturation level. If it is not weaning off, it's not going down, then wean off. Wean off for some time. And then you see what is the saturation level. After some time, when it comes down, again you start. Clear about it? Then exercise training, inspiratory muscle training. Inspiratory muscle training. How do you do the diaphragm muscle training? How do you do this thing? Okay. So diaphragm muscle training, everything. I'll try to show you my videos about the diaphragm muscle training. It's very easy. Don't worry about it. Now, other major strategy, major group of strategies, what? Increase the energy supply. How do you increase the energy supply? You have a beautiful oxygen therapy. You have a better mineral balance, what we say, the fluid electrolyte balance, and then we have a better nutritional management. Apart from that, we have a oxygen delivery to the inspiratory muscles. I mean to say, whenever you are saying the patient, okay, look, these patients have predominantly apical breathing, right? So if you try teaching the what we say lateral costal, posterior lobe breathing, all these techniques, they'll have inspiratory muscle strengthening. You can't have a strengthening like a bicep, right? But we have to think in that way. We have to resist and we have to train. I'll let you know in my video like how to do the chest wall exercises for strengthening those lobes. Sorry, those muscles. Now, techniques to reduce the work of breathing. As I was telling you, apart from the strategy, these all are the explanation of strategy you will find in your manual. Handling breathlessness people, sleep and rest, positioning, relaxation, all these things. Okay. Then tips to reduce dyspnea. This I have given you as a tip. Okay. So this just keep as a like a tip for you. I have given to you. You can use for your patient. Avoidance of the breath holding. Tell your patient not to hold breath, because holding breath is always not good. It depends upon which kind of condition, which kind of patient they need to hold the breath. All the patients are not supposed to hold the breath. Then using a fan. You know why? Suppose somebody getting suffocation, say for example, then why do we say, oh, this is needed, fan is needed? then we say like fan is needed. Okay, why do we say fan is?
Please share the screen.
Yeah, just a minute. I wanted to share different screen, so just 1 minute. Yeah, so why do we say the fan is needed? Have you ever imagined anybody getting what we say that kind of breathlessness in any public place or anywhere? We say let us switch on the fan. Okay, why do we say that? Have you ever imagined why do we say that? This is because it influences the receptors in trigeminal nerve distribution that provides information to sensory cortex. So breathlessness case में, in that case we definitely need to have a flow of air. Okay, it is to activate the trigeminal nerve receptors. Okay, so anybody ask you, you can answer this easy. Now let us talk about other points like mechanical vibration over chest. These all are the tips. Look what happened. These tips you may not get in all books, but you can use for your patient. So what happened? Mechanical vibration on the chest. Okay, that decreases the breathlessness. Okay, then self acupressure to any of the following. I have given certain points. Okay, so anterior midline between the nipples at level of 4 intercostal space just below the each coracoid process, and then 1.5 thumb with lateral to the lateral border of each T3 spinous process. So these all are the certain what we say boost for you, tips boost for you, can use for your patient. Okay, before getting into therapeutic body positioning, I'll stop sharing the document now. I'll just give me 2 minutes time. I'll arrange my board. Then I will explain about all the major concept, 15-20 minutes. Then I'll give you a break for about 5 minutes or not more than that because we are already late for 15-20 minutes. Then we'll continue our video demonstration. Well, so just 1 sec. I'll switch off my second device video and switch on my laptop video so that I can show you my board. If you have any difficulty in watching the board, just let me know. I'm arranging it. Just give me 1 minute. 1 minute. We would need board for many times in the day. I believe even second, third time we need that. Okay. Yeah, everybody can hear me, right? Everybody can see the board in front of you. Everybody can see the board in front of you?
Yeah, yes, sir.
Yeah. Okay, fine. Thank you. Well, look at here. We have 2 axes. Okay. This we say as x-axis. This we say as a y-axis. Fine. I am drawing. First, you see. I am drawing what? This is for the lung. This is for the chest wall. This is the intersection point, what we say as FRC. What is FRC? Functional residual capacity. As a physio, you must learn this concept. If you will not understand, I will tell you for 100 times. If not that is enough, I will tell you for 500 times. Here, this is the lung volume. I mean, lung, it is a volume versus pressure versus volume graph. Okay, don't confuse between the flow versus volume. I'm telling you very clearly. It is not flow versus volume. It is a pressure versus volume. So when your lung start inspiring, it always remain positive. Always remember, lung pressure don't go into negative. So your lung has to struggle a lot to fill up the air, right? That's how the volume increases as well as the pressure goes up, right? Sorry, the pressure decreases and the volume goes up, right? Then what happened? The chest wall, it always starts from the negative and go like this, negative to negative. But chest wall and lung combining together, that will be passing through this. What is this? What is this? This is FRC, functional residual capacity. Can anyone explain me why did I take this so serious, FRC? Reason behind, when you are breathing in, okay, and when then you are breathing out, at end of the normal expiration, this is called your FRC. That is what? Expiratory, what we say that reserve volume, ERV plus TV, right? So that is what your FRC is, right? Sorry, ERV plus your dead space volume. No, sorry, I'm actually mistaking. Sorry, FRC is equal to your residual volume plus expiratory reserve volume. Clear about it? So at end of normal expiration, this is what is happening. So chest wall pressure and lung, what we say that intrapleural pressure and intrapulmonary pressure, both are equal at that point. Is it clear? That's the reason it is always at 0. So now everybody's talk about compliance. Why did I tell you to not to get confused with the compliance? Is mainly because what is compliance? First try to understand that. Okay, once you understand what is compliance, it will be easy to understand for you this concept. Wait. Look, compliance, what we say. What is compliance? Everybody talk about compliance, right? What do we say as a compliance? Anything which can extend and which can have volume, okay, which can increase in the volume and which can extend also, is said to be compliance. Okay. Now, say for example a balloon, you fill up the air, right? You fill up the air, it will extend for some time, but it cannot create a lot of volume. It will have a limit of volume. Isn't it true? It will not be said compliant enough. Or suppose a wooden mug or plastic mug, 100 ml mug, you are filling up with the water. Okay, it can contain the volume. It can keep the volume, but at the same time, it cannot increase its amount. Can it increase more than 100 ml? Say for example, I have given you 100 ml of cup. Can it increase its amount? No, it cannot increase, right? It won't be said as a compliant. Why did I tell you to understand what is compliance? Because it will work now. After knowing what it is, it will work now. See. So, in chest wall, as well as the pleura, as well as the lung volume, everything how does it work? You see, air coming in, going out, not always simple like this, isn't it? it's not always simple like this. In later today, we'll be discussing about equal point of pressure. Or you can see now only how does it work. Suppose the pressure is 12 here, okay? While coming here, it will be 10, 8, 7, 6, and after leaving that 5, 4, 3, 2, 1. Suppose this is the pressure graph, okay? But when there is a pressure of the pressure entering into the alveoli, what we say the atmospheric pressure, or which is causing the elasticity, it is filling the air into the alveolar sac. So that is inflating this, okay? In that case, intrapleural pressure, which is negative, is not able to dent it, okay? It goes decrease so that the air gets fills up. But when it starts moving up, what happens? No, at one point of time, intrapleural pressure becomes equal to this. What is it? This. So this can get collapse. But does it happen? No, it does not happen, because in general, for a normal person, this is supposed to be equal at this level where you have a beautiful cartilages, which doesn't let it to go reduce. Clear about it? But in the case of, say for example, COPD, okay, what is the problem in COPD? Most of the time, you know that problem is the expiration, right? Inspiration is never a trouble. Expiration is a trouble. So in this case, what happened? You see, suppose there is a mucus plugging here, here. Okay, there is a mucus plugging. What is happening? The air is coming inside, no doubt about it. But while going out, this air loses the pressure much earlier. Okay, it loses the pressure much earlier. Because it loses the pressure much earlier, okay, this can get collapse here. If it can get collapse here, game is finished. Alveolar will be, after some time, alveoli is of no use. In general, I'm telling you, physiologically, no use. And if you leave it for a long time, anatomically of no use. You know, it will convert into the physiological dead space. Isn't it clear? Everybody, if you have understood, give me thumbs up. Otherwise, we'll talk about again this later. I mean, sorry, now only. Reason behind, I told you, if you don't understand, I'll make you understand for 150 times. If you ask me 500 times also, I have no problem. Because these all things I am going to ask at end. I am not expecting 100% answers from you, but I expect that at least you understand the basic concept. Okay, I'll check the
So please unmute.
Yeah, after the press.
Yes, sir, please go ahead.
Yeah, after the air gets inside the alveoli, pressure becoming less, and then it will go out. For normal person, it becomes less in such a way that intrapleural pressure matches the intraalveolar pressure at much higher level. That higher level, you have a beautiful cartilage which doesn't let it go collapse. It doesn't collapse. Okay, it does not collapse. But for the person having a mucus plugging here, it is very sure that the air will lose the pressure at this point, and intrapleural pressure becoming more, it will collapse the alveoli. Is it clear now? So it will be collapsed, right? Is it clear now? Because of mucus plugging, I'm telling. Anybody has any difficulty? Yes, sir. Okay. So anybody can ask me 200 times. I have no problem. Anybody can ask me 200 times. I have no problem. Definitely, Mahindran, definitely. sorry if I could not pronounce your name well, definitely that is the airway resistance. Resistance matters. This is what I'm saying you, that normally textbook, normally our experience, everybody talks about alveolar pressure, intrapleural pressure, but very few places we talk, even compliance, but very few places we talk about chest wall pressure. Very few places we talk about the resistance through the airway. Airway resistance is very, very important to understand. So what I was trying to tell you, that suppose there is a mucus plugging which will create resistance for this air to go out, right? It will create resistance for this air to go out. So that is very possible. That is quite obvious. This air will lose its pressure much earlier because of the ongoing and constant intrapleural pressure. Because intrapleural pressure has to work. After the inspiration get finished, the pressure start reducing there. The intrapleural pressure has to go more above level, what we say positive level, but that is negative for that. Intrapleural pressure never becomes positive. What I'm saying you, that goes for more positivity. So at this level, suppose there was going -2 or 0. Say for example 0. Forget about it. 0. It never happens in general, but 0. Or any intrapleural pressure. But intrapleural pressure will get equalized to normal alveolar pressure of the air going out at much earlier level, and that level you have no cartilage, so it will get collapse. It will get collapse. Now it is clear. Anybody has any doubt, again ask me, no problem. I want you to use your Sunday in scientific way. Clear about it? I'll check some chat option. Is there anything? Now clear, thanks. Okay. Well, now somebody asked about the airway clearance, this one, no? Like resistance. Yes, we'll talk about my resistance. Yeah, sometime back I asked a question. Question was about why do we say bronchial asthma? Why do we say bronchial asthma? We don't say bronchial asthma. Listen very carefully. Today's class, this particular part is very important. If you don't understand the video demonstration that I can send you as a YouTube or Google Drive, you can see 100 times, that's not a problem. Okay. But if you understand this, techniques will be easy to understand. Okay. Well, look at here. After learning the equal point of pressure, yes, resistance work. So anybody got doubt, this clear? Sorry, anybody got clearance about why do we say bronchial asthma? Why don't we say bronchial asthma? Anybody? Okay, no problem. Look, this is the bronchus. Then we have a bronchiole, right? Correct? Correct? Learn nicely. Diameter of this, we will denote as a big R. And these all will denote as a small r. Okay? When it is a resistance matters, just now we spoke about this, what we say that mucus plugging, right? And this is anyway conducting zone, not a oxidating zone. I mean, what we say, not a respiring zone. You know what is conducting zone? Where there is no respiration process occurs. So a small r, and this is a big R. You know, summation of all the small r, what we say as a sigma, small r is much bigger than the r. Understood now? So resistance of every small bronchioles will matter, not the big one, not the terminal one. Now clear about it? Is it clear? Why do we say bronchial asthma? We don't say bronchial asthma. Because resistance matters here, right? Now what happened? This small r is much bigger than this r. So resistance is more. More resistance means flow will be reduced. If flow will be reduced means pressure will be reduced. Okay? Then our alveoli get collapsed all the time. Why it is not collapsing? First reason, I told you the air goes always and get, like equal pressure, equal point of pressure build up at this bronchiole, terminal bronchiole. Okay. And second reason is something called surfactant. So before knowing the surfactant, let us talk about something beautiful concept called collapsing pressure. Okay. What is collapsing pressure? Collapsing pressure. Collapsing pressure is formula is 2 into surface tension divided by radius of bronchiole, right? 2 into surface tension divided by radius of bronchiole. Well, now it's good to know. So what is surface tension? Surface tension is always created where there is a two different medium, air and fluid. Okay, so in the lung there is a surface tension. So which reduces the surface tension? Suppose here you have a more surface tension. Okay, normal radius of bronchiole. So what happened here? Collapsing pressure will be normal. But if surface tension increases, then what will happen? Collapsing pressure will be more, means more alveoli will collapse. Now come to the another basic concept. Suppose surface tension is normal. Now somebody has a more asthma. So what is happening here? Radius of bronchi getting decreased, correct? It is getting decreased, right? If it decreases, if denominator get decreases, total outcome will be higher. Total outcome will be more. That means more collapsing pressure. That's the reason in COPD or asthma or in this condition, like collapsing pressure is more. So their normal breathing will not be there. Okay. So you understood now? You understood now? This particular thing get decreased because of mucus plugging, collapsing pressure will increase. So this formula keep in the mind. Now, there is something called the concept of pulmonary ventilation and alveolar ventilation. Okay, before that, to clear more about surface tension, let me talk about surfactants. Surfactants are the chemical you would have learned in your first year of physiology that reduces the surface tension in general. So you have a surfactant in your lung which decreases the surface tension so that it becomes better. Now, as I told you, before going to the other concept, let us talk about, before going to the ventilation, let us talk about surface tension, why it matters. Suppose there is a alveoli where you have a air, okay, and here you have a saline fluid, suppose, okay. So saline is a fluid, saline water is a fluid. That fluid and this lung, what you say, that interface, this fluid will have a less surface tension because of the same media. But here, the media is different. Air and liquid, surface tension is always more. So you have, God has given you surfactant to reduce the surface tension so that you have a reduced collapsing pressure. There is no chance of collapsing for a normal person. Okay. Now talk about infants. Okay, infant. What is happening in infant? Infant has a small lung, of course, a small body, so a small everything. So in that case, what is happening? See the formula, collapsing pressure is equal to 2 into surface tension divided by radius. Everything is small here. So what is happening? Can anybody explain me what happens when the baby get born? Look, I'm talking about normal delivery. Okay, so normal delivery. Listen very, very carefully. In normal delivery, baby's head come out. Clear? Head get pressure. Pressure is there or not? Pressure will be there. Do you know how beautiful the nature is? If there is a head pressure on the head increasing, there is a stress hormone. Anybody can tell what is the stress hormone? Any one hormone? If you name, I'll be very happy. Okay, I'll only tell you. Cortisol. Let all of us happy. Cortisol. Okay. Cortisol. What we say, prolactin. You know prolactin, one of the mother hormone we say, prolactin, right? Yeah, wonderful, wonderful. Cortisol, somebody told you. Yeah. Pooja, okay. Well, thank you, Pooja. So what happened? Prolactin, these all things work as a surfactant to decrease the surface tension for the babies. So now you understood the value of normal delivery, how much it is needed, because after baby get born, we wanted to cry. Why? Because we want the air to get filled, right? But before that, you see how beautiful the nature is. It actually produces these chemicals to reduce surface tension. So we must be thankful to the nature. We must be thankful to our mother. How nice the system of the nature is designed, you see. Surface tension decreases, collapsing pressure remains nullified, and baby born and leading a normal life. So I'm sure that you have understood the concept of collapsing pressure. Anybody has any doubt, please tell, because we will be moving to the next concept of alveolar ventilation. That will take hardly 5 minutes to make you understand, because you guys know about it. Anybody has any concept problem in this? You can just write it, type it down in chat option, because chat box is open to me. I can see everybody's chat. Anyone has anything to ask? Even at last you can ask. There's no problem. I told you, you can ask me 500 times. That's not a problem. No doubt? Well, okay. I'm moving another concept called dead space. What is dead space? Anybody can tell me? Because these all concepts I have not made it, and what to say, is there in it's not there in the manual, this higher concept. These all I have kept as a copyright. So whenever you learn from me, I'll let you know. Wonderful. Somebody has explained the dead space area. Yes, we have two types, physiological and anatomical. For normal person, the physiological and anatomical are equal. And for, of course, pathological issues, we have more anatomical, this one, what we say, anatomical dead space. In that case, physiologically, dead space also increases. Now, let us talk about what is the dead space volume. How much is the volume for dead space area? Can anybody has any idea? Okay, you think about it and just let me know. Before that, we'll be calculating it. This is the alveoli, okay? It all depends upon the CO2 pressure, okay? So CO2 pressure, while going, what we say as a PA CO2, let us talk about this artery. Arterial, this alveolar, and then there is something called the arterial CO2 value. Okay, how do we talk about it? I mean, we can actually see this. It is actually 150 ml. How it is there, I'll let you know. Normal tidal volume, if you divide by alveolar CO2, say for example, that is 6 and minus 4, which is in the blood, because you know more production of oxygen is there in this, and then divided by this alveolar CO2 pressure. So if you divide this tidal volume, if you take 500, then that comes by 2 by 6, that is 166 ml. So approximately 150 ml is your dead space area. Always remember that. Okay. Okay. Well, in this case, now let us talk about how do we calculate the alveolar. I mean, what do we know about alveolar ventilation and pulmonary ventilation? I'm taking breathe like this is the pulmonary ventilation. What I'm trying to do here, respiratory rate into tidal volume. Say for example, respiratory rate is 12, tidal volume is 500, so that is about 6,000 ml air. This is a pulmonary ventilation. Okay, some of the yoga position also says this, but otherwise for normal person it's not there, right? So now in this case, if we talk about alveolar ventilation, even though they have taken, I mean, you have a 6,000 ml of pulmonary ventilation. In this case, if you talk about alveolar ventilation, that will be respiratory rate again into tidal volume, correct? Tidal volume minus dead space. Okay, because alveolar ventilation was how much? Tidal volume minus dead space, roughly 350 ml. So now if you calculate 12 into 350 ml is about 4,200 ml. So this is the pulmonary alveolar ventilation. So there is a difference between alveolar and pulmonary ventilation. So there is a difference between pulmonary and alveolar ventilation, right? Now you understood the concept. Is it clear about this? Everybody is clear about it? What is pulmonary? What is alveolar ventilation? What is the difference? How do you calculate? How do you calculate? Yes, very good. Thank you so much, Mahendran. If you have any doubt, you can ask me. So with this, we are almost finishing our second last concept, basic, very like advanced concept of dry, what we say, dead space, air, everything. Now we'll be talking about again a graph. Okay, again a graph, and this graph is going to be the most important graph. Okay, first let me draw it, then we'll be talking what it is. Pressure, volume. Okay. Okay. This is how our inspiration and expiration work. I just wanted to let you know. Okay. First, you see about the just a minute. Pressure will go on top always. This is how the volume is. Okay, you see, how does it work? From the FRC value, suppose somebody started inspiring. Of course, they will create the negative pressure inside, then only the oxygen will get into. Clear about it? But when it is an expiration, it will go like this, and it is a passive process, right? Now let us talk about the time. Very, very important concept of time here. When you expire, just breathe in. Okay. FVC, forced vital capacity. And then you have a concept called FEV1. Okay. How much expiration happened in first second, right? 1 second. So FEV1 is equal to almost 80% of FVC. True. This is what we have learned. See, in 1 second, how much air it goes out. More amount of air goes out in general also. Okay. So now the rest amount, it will go slowly out. This is for the normal person, I am telling you. For the normal person. Okay. Now think about somebody has restrictive lung disease. What will happen in that case? Why I'm starting from here, I'll explain you just now. First of all, the total lung volume will be less. After that, there will be a kink on this. Why? Because their inspiratory capacity is so less, then while expiring, it will be slowly down and then it will come out. Okay. Suppose somebody has a COPD. Good volume will come inside, but while expiring, very difficulty, it will go like this. And somebody has both problem, restrictive as well as obstructive, the graph will be like this. Okay, this is the concept. Any restrictive lung disease, the whole graph will be shifted to right because there is a less volume going inside, and while expiring, their chest wall is not working in an efficient manner. See, so there is a kink. Initially it will be good, but there will be a kink later. So you have a measurement, right? FEV1, if you see in the spirometry graph, you have a different measurement, right? So if it is around 60 to 70, they say moderate. I mean 40 to 50, moderate. Below 30, anyway, it's dangerous. So below 50, this graph will come. You see, you check in your hospital, you'll find it. Okay. So at end of this class, I will explain this concept once again. The reason behind this concept will work for you clinically to assess people. Okay. And one more concept in this, you know what, since it is little more hazy, let me make it very clear for you. How do you differentiate this one? So for normal person, I told you, this is how it goes. Okay. For COPD, it will be like kink kind of thing, and will be good inspiration. So in this case, if any doctor asks you how do we differentiate between the spirometry, or for your, you know, like understanding, you know, if you give the beta-2 adrenergic, beta-2 blocker, what you say, drug, for the person like asthma, they will have a better graph, like a normal person. But for COPD, graph will not get corrected. That is the major difference. Okay. So again, we will be explaining this concept with more clarity when we come back to our end of the class. So class will go for a little longer time. Bear with me. Cooperate with me. So at this point of time, I have explained about almost all major concepts. So let us break for about 10 minutes. Then 10:30 or 10:32, we will be aggregating again. So till then, we are breaking. So note down your question. We will be having some video demonstration because in COVID time it's a bit hard to get the model. Still, I have tried to get. I'll see if I can get model for some of this one. Otherwise, I am having a better video. I can explain you one by one while it will be running. Okay, fine. Let us break for. See you, sir. We are breaking for 10 to 12 minutes. We'll be back once it is 10:32 or 10:33. Thank you. can see this. Yeah. If it is not coming screen sharing, please let me know. Yeah, it is there. The deep breathing. The techniques will start from here. Yeah, it starts from here. So we'll start with the positioning. I'll switch on my video from this very part. And I'll focus my webcam also. Able to hear everybody?
Now I think that camera, this audio also working.
Able to hear? See you, sir.
So I think in the laptop, the audio is, we can hear also.
I have switched on the audio on the cell phone.
Can you switch on the laptop audio and switch off the mobile audio?
Because laptop audio was a problem that time also.
Now, can you try once again the laptop audio?
Okay. Now is it or
You're talking from laptop or mobile?
I think laptop audio has some problem. So
Okay then.
I'll share the screen as well as I have called even the model also. It will take some 5-10 minutes. Before that, I'll start other part of this program, like exercise prescription and other things. So I think model is on the way. Anytime he can come. So for 1 hour, I can demonstrate easily. It will be better rather than running video.
Okay, sir.
Let them have a better like a live demonstration. Model is on the way, is coming. Meanwhile, I'll share that already has been shared the documents. So you see, positioning we'll be talking about in restrictive disorders as well as in the obstructive lung disorder. So restrictive lung disorder, let us talk about pleural.
We can see the screen, sir.
You can see the screen, right? Okay.
Please share.
Okay, I'll do it. Just a minute.
Systolic 203 millimeters.
Yeah, so it's a positioning in restrictive lung disorder. I hope that it's been shared.
Yes.
So talking about pleural effusion, so make sure that it is in the side line with affected side up. So generally the side up rule is always good, and the pneumothorax lying on good side is comfortable with optimal ventilation to perfusion matching, and lying on affected side may speed up absorption of air. In case of bronchiectasis, okay, in case of unilateral bronchiectasis, leg and is often elevated. Why? Because we want assist from the gravity, and is often elevated with affected side uppermost. Bilateral cases, unilateral lung bilateral cases, it's always good to go with the supine lying position, and always remember the bad lung up rule. Though we have exception of recent pneumectomy, large pleural effusion, bronchopulmonary fistula, and a large mainstream bronchus tumor. Why do we go for the bad lung up rule? Most of the cases, in initial cases, if you see, many of the patients in hospital, they have this intercostal drainage, right? So intercostal drainage, it's always good to get drained in assistance with the gravity. That is the reason we want same side down, like the pathological side down. But in general, the rule is bad lung up. So you should be very clear about it. Okay, what all the exception and why it is exception and why it is needed. So recent pneumectomy, large pleural effusion, bronchopulmonary fistula, and a large mainstream bronchus tumor. So these all are the major exceptions to the unilateral lung pathology where the bad lung up rule will not be followed. Fine. So positioning, next positioning will let us see in the obstructive lung disorder. Obstructive lung disorder, just a minute, again I'll share. Obstructive lung disorder, generally, if you see the acute exacerbation of asthma or any COPD, in fact, the patient accessory muscles should be facilitated. 1 second, screen will be in front of you. Is there in the manual also. Anterior pelvic tilt facilitates the accessory muscles. Can be achieved by placing towel roll vertically along the supine, vertically along the spine in supine line, or during a stable phase, pelvis should be posteriorly tilted to facilitate the diaphragmatic muscles that I explained you earlier how it is possible.
Sir, screen we can see.
Yeah, it will come, sir. It will come. It can be achieved by placing a pillow below knee. In base supported arm positions, serratus lat muscles as well as the pectoral muscles are told to do reverse action. So even though this is very good for the postural management, I mean the postural correction. To follow positions for dyspnea, we'll have to follow, depend upon the kind of acute, subacute or chronic it is, we have to follow the dyspneic position. So now it's a PNF respiration. So model still hasn't come. So another 5 or 10 minutes, I believe. But till then, we'll be talking about other things, which is not part of demonstration. The moment model comes, we'll start this. So till then, I'll be talking about how the electrotherapy is important for cardiorespiratory disorders. The screen will be in front of everybody. So biofeedback, I was talking, it is the procedure by which the information about physiological function is feedback into the individuals by means of auditory or visual signals. In asthma, it is used to control airway resistance. Researchers says it's due to afferent pathway of trigeminal nerve would be capable of altering airway resistance through its effect on vagal output. So these all parts are there in your manual. I would tell you to go through this very clearly and you use for your patients. I have given even the tips and techniques like how can you use the tense. It can increase the, again it will come, it can increase the PFR, it can, because it decreases the tension in the frontalis muscle. So this is how So in COPD, generally, it is shown to increase tidal volume, decreased respiratory rate, and increased maximal oxygen uptake. It is shown to relaxation of accessory muscles and reduction in some muscle tension also. So screen will be in front of you. There is some disturbance in the screen. I don't know why it is not coming very regularly. But anyway, the manual will be sent to you in this, the manual, everything is there. These all small tips have been given. So even the short wave diathermy, TANS, I'm just waiting for the model to come. Keep hold for 5 minutes or 10 minutes, he's on the way. You can check with the short wave diathermy, application of short wave diathermy and medium wave diathermy increases absorption of air, but again you have to use carefully these machines because many countries it is not permitted. As temperature is directly proportional to the pressure, this is the biophysical principles in this. If temperature is directly proportional to the pressure, in general we know there will be increased pressure in pleural space, which increases absorption, as there will be vasodilation of pleural capillaries, which further increases absorption. It works well for the postural pain arising due to disturbance in biomechanics of body posture. So please use for the most of the postural pain. It is really good to follow that. Yeah. So in general, electrical stimulation, if you see, It's there in the manual again. I have given this, even the points and frequencies you need to do. So what all things you can do with this? You can do the weakness, atrophy, structural and metabolic changes that have been observed in the limb muscles, which in turn can have negative impact on exercise tolerance. Dysfunction is characterized by reduced percentage of oxidative fibers. If you learn about type 1 and type 2 fiber, that will be very easy for you to understand why electric stimulation is so important. You can read the read various books also, even the Low and Reed book in electrotherapy, they have explained it well. Decreased activity of most oxidative enzymes and reduced capillary to fibers ratio. This is very, very important concept where actually it works. We actually advocate the use of electrical stimulation in the pulmonary cases. Electrical muscle stimulation you can apply even on the accessory muscles like quadriceps, hamstrings, calves, and gluteal, because you have reported you have a physical activity reduced, right? So once it has been reported in that way, so you can use these muscles also. What we say that in terms of what all we have kind of what kind of common mistakes in cardio. Okay, I saw your question. Yes. So in general, you can actually apply these things, and quadriceps, hamstrings, calf, gluteal, these all muscles are anti-gravity muscle where actually you need a lot of eccentric contraction to maintain your posture as well. And then next is in this, if you talk about like what kind of parameters you need to select, the pulse duration of 400 up to 400 millisecond, you can select 8 to 50 hertz of frequency, and then intensity 10 to 30 milliampere. So you have to have a normal low frequency current for doing such things. So I think most of the time Faraday current will suffice the need. Galvanic, we don't need here. So it improves muscle function, exercise performance, and muscle size, peak torque. We have a various kind of muscle performance current also, like a Russian, Reebok. So all those currents you have to decide according to the pre-morbid activities of the person, of the patient. Electrical stimulation induced a preferential increase in type 2 fibers according to some research. Now, if you talk about TENS, it works very well in the reduction of dyspnea in COPD. And application, I have given a beautiful explanation like how can you go for application even with the point I have given, 45 minutes of acute TENS. But apart from all those things, you can go for the decrease in pain after the rib fracture. Very, very important. Dry pleurisy and following thoracic surgery. So it's really very important. For dry pleurisy, kind of acute pain, TENS used here is a high frequency and low intensity for 40 minutes. Okay. Mechanism is something like a blocking A delta by stimulating A beta fibers. Okay, so for post-operative thoracotomy pain, I usually prefer this thing. Why? Because brief TENS just for 5 minutes that you can use for the high frequency and high intensity, even with the breast and PWM mode you can use. It will reduce the pain by activation of A delta fibers. Electrodes are either placed above site of incision or on the either side of incision. So as one participant asked me the common problems in the cardiopulmonary physiotherapy, common mistakes what do we see? Common mistakes, what we actually see is the first and foremost thing is positioning. So if you don't have a better positioning of your patient, I'm telling you, it's not going to work. Why? Because no matter what, if your patient has, say for example, let us take an example. It's always good. Say for example, it is a condition of pneumectomy or lobectomy. Let us say lobectomy. What happened in lobectomy? In this case, as I told you just 5 or 10 minutes before, like a bad lung up rule and all those. So bad lung up rule will work only and only when you have a selected. You have selected proper data in your assessment for the patients. Suppose it's a new case, acute case. In that case, you can't remove the intercostal drainage, right? So to have better intercostal draining, you need to keep the bad lung down. But when it comes to the, say for example, after some time, so in that case, for better chest wall mobility, you need to go for the supine line. So it all depends upon what do you actually select. And other mistake is selecting your exercise. So most of the time we start with the basic exercise, that is your diaphragmatic exercises. diaphragmatic breathing, deep breathing, or sorry, diaphragmatic breathing. In that case, we feel that diaphragmatic breathing is only when the person is sitting in the half lying or semi-lying. That is no. Diaphragmatic breathing even it can be done when person is sitting normally without support, and diaphragmatic breathing even can be done when person is standing. I can show you that. Okay, it's a very relaxed manner with the wall, support with the wall, that can be done. So all these mistakes, yeah, definitely in the basic level we do. And then after that, with every patient, we have a different design of protocol. Like when you want to move, if you want to move early, you can move early. If you don't want to move early, if patient condition is not that, you can move, you should not. And the next is the bigger mistake is, like suppose you are your patient is a head injury patient and he is on the CPAP. So while making him sit and he is head injury, so of course you are not supposed to, you are not expected to, you will not expect actually to be his head straight, right? He'll have a head loss. So there is a pressure on his tracheostomy tube. In that case, if you remove his oxygen for that point of time, he will have a compression on this. So that all points you should look. So when he's sitting, you should have either you can put a hard collar, hard neck collar, so that his neck is like this. But all the time you can't keep the neck collar, right? Even though anybody says you can keep neck collar, how will you keep neck collar? If you keep a neck collar here, how the oxygen pipe will be so comfortable? So positioning of the patient is the most important factor in this case. So these are the common mistakes we are doing in hospital, in OPD. And then when it comes to the pulmonary rehabilitation and those groups and clinics, in OPD clinics, there we have exercise prescription. How do we go ahead with the exercise prescription? So I'll let you know about this exercise prescription. I'm sure it has been shared. The document is shared. So in this, you can see the exercise prescription. Exercise prescription, it does not go so like a relative way. You have to have a better data for that. Then only the exercise prescription can be comfortable. Yeah, so exercise testing and prescription, if we see, in this case, exercise testing has to be done for both upper limb and lower limb. That you need to always keep in the mind. It is the upper limb as well as the lower limb. So never ever do the mistake of just doing in one limb. Like suppose we have done for the lower limb and we haven't done for the upper limb. So those things should not be there. So that you have to keep in the mind all the time. We have to do this for the both the limbs. Okay, so you can see even in the screen, it is, I have given the various prescription details. Like lower limb, you should have a normal 6-minute walk test is performed. Again, it's not a hard and fast rule. In upper limb, supported upper limb exercise test with cycle ergometer and unsupported upper limb endurance test is to be performed. After test, heart rate, BP, respiratory rate, Borg RPE data has to be recorded immediately after 3 minutes of exercise testing. So this is very important. Okay, so if you see exercise testing, it is a big chapter because it needs a lot of data to be taken. Then only it can be done. Now prescription part. After testing, you will go for the prescription. Aerobic endurance training can be performed at high or low intensity. High intensity training, 70 to 85% of maximal work rate improves aerobic fitness, such as VO2 max, you know very well, delays anaerobic threshold. Decreased heart rate for a given workload increases oxidative enzyme capacity and more capillarization of muscles. Low intensity exercises in general, low intensity exercises, if you see in general, that improve your endurance. But again, it won't increase your strength, right? So as a physio, you should be very careful for even the strength. From day one, you should work on the strength too. Component part, if we talk about component, if we talk about, say for example, component of exercise prescription generally includes exercise intensity, duration, frequency, course and progression and type of exercises you are selecting. It can be supervised or unsupervised depending upon the patient, number of days he has finished in his hospital and then later in the OPD. Now, lower limb training, particularly very important. I have given in detail like how, which all mode you can select, but again, it's not mandatory for everyone. For lower limb training, walking and cycling is preferred. Swimming for combined training in later phases, and rowing machine in OPD if you have. Intensity, subjective rating always preferred over objective like MET, maximal heart rate method, or 12 to RPE score, as everybody know box scale. This has to be preferred. Target heart rate you have to calculate, and then exercise heart rate won't be crossed in that training. That you have to be very, very carefully seeing that. Duration and frequency, initially 1 to 5 minutes daily several times for overall 30 minutes. Warm-up and cool-down is incorporated. Warm-up period allows gradual rise in heart rate and BP, ventilation and exercising muscle blood flow. Cool-down reduces the risk of arrhythmia, orthostatic hypertension, and bronchospasm. Upper limb training is given in both obstructive and restrictive lung disorder. For upper limb training, supported exercise training is given in acute exacerbation, and unsupported training is given in stable phase. Always remember, upper limb training is very, very important. In case you may have to start maybe a few days later, but you have to. But when both hands are elevated, lower floating lips move more outwards. So that has capacity of, engulfing more air for the lower lung zone. That is what your target should be. Chest mobility exercises, what we are going to see in some time, where deep breathing is incorporated, chest wall adhesions are prevented, increases expansion of lower lung. Upper limb activities commonly require unsupported arm exercises, which poses a challenge for COPD patients, whose upper limb muscles work as an accessory in respiration. In supported type, there is less load on diaphragm, but in unsupported type, there is a shift of respiratory work on diaphragm associated. That is what we say the thoraco-abdominal dysynchrony. Severe dyspnea and termination of exercises at less workload, especially in severe bronchial obstruction. So be very, very patient while doing it. You may take more time, but don't do it very harsh. If you see more about this, then you have a supported arm exercise, is also called arm ergometry, and then you have an arm cranking exercise, train at 60% maximal work capacity, increase work every fifth session as tolerated. Okay, you increase every fifth session. Then exercise period should be about, say for example, 30 minutes, not more than that. Unsupported arm training is also done with the weight, starting dowel with 750 gram, lift weight at shoulder level for 2 minutes with rate of lifting equal to breathing rate, followed by rest of 2 minutes. So this is again not hard and fast rule. This is a kind of guide for you. Repeat sequence as tolerated up to 32 minutes. Patient should be monitored for dyspnea and heart rate. Progression of exercise, weight of 250 grams should be increased every fifth session as our patient tolerates. And after the progression of exercise, you need to see unsupported arm exercise without weight can also be done as follows. Why? Because you want to increase the endurance. Of course, it won't be giving you enough benefit in strength, but yeah, like throwing a ball against the wall by keeping shoulder horizontal in sitting position, or passing a bean bag overhead in sitting position, or exercise overhead pull in sitting position. These all are for the endurance purpose. Okay. Duration, each performed for 40 seconds followed by 20-second rest. And exercises have to be repeated 4 times in 4 minutes. Same thing, 4 times in 4 minutes, because 40-second activity, 20 seconds rest. Now, if we talk about strength training, weightlifting leads to improvements in muscle strength, increased exercise endurance, and fewer symptoms during the activities of daily life. Now, how it has to be done, I'll demonstrate on the model. Some of the things, what the pulmonary rehabilitation part, you can start right from your OPD or maybe from your patient's home. Lower limb muscles can be strengthened with aerobic training itself, and upper limb muscles can be done with low resistance of light weights and progressed by increasing repetitions starting with 10 or 20 before adding additional weight. Therapist must monitor breathing pattern, and very, very important to monitor even with the the pulse oximeter, means oxygen saturation. Very, very important to maintain the oxygen saturation, because oxygen saturation is something, if you don't maintain, it may go haywire, because your patient may lose in between. If it comes below the 70 or maybe below 80, it is actually the red signal, right? So oxygen saturation is equally important. Now, if apart from these all, flexibility exercises improves the posture. So for flexibility exercises, you have to do in such a way that it does not stress enough on the lungs, but yeah, it actually gives them what we say that more freedom to go with their activity. That is how it is important. And apart from that, it actually decreases even the stiffness. So this is how we always say that this particular part of upper limb is equally important. No matter what, you can actually use even later. So I have stopped my screen sharing for some time. This is how we have done with the basic concept and advanced concept till now. We saw how we can, somebody asked me what is the common mistake we do. I explained that too. And then apart from that, I explained about the electrotherapy, what we use in pulmonary rehabilitation. Then I explained about upper limb and lower limb activity. Then I explained about strength training as well as the endurance training. Then I think I explained about the common mistakes what we made in pulmonary rehabilitation, like how better we can go. What is the benefit of not just strength and endurance? What is the what is the benefit even for the flexibility exercises in this? So till here we have finished all these parts. Now before we start on this next part, let's have some question and answer session. I want you to unmute and ask the question. So then we can go for next part. Even with the techniques I have given in the manual, so you can ask your questions before we start our other things. You can ask any of the questions whatever we have finished till now, because another 1.5 hours we'll be talking about techniques. The moment model come and we can start it. Meanwhile, I'll try to send the document of I'll try to send the document of cardiopulmonary, whatever the manual I have prepared for you. So I think that will be too good for you to refer, as well as refer during because I want you to switch on a video, and if it is possible that you can just refer this cardiopulmonary manual during the technique. So you have a bullet points in technique. So just a minute, I'm in the process of sending that. I'll search it and send. So yeah, you have any question, please ask me till here. Yeah, it actually affects, because we need to understand why it happens first. Why it happens first, we'll have to understand that. I'm sending this particular again, the PDF will be sent to you, no doubt, but till then it is for your reference while learning yeah, I have sent on the group. You can download in the PDF. Okay, so this will be good for you to whatever I have explained you, basic concept, but whatever I have explained you bit advanced, like a Farsi and all, it won't be in this, because that is something to be understood. And then yeah, a participant asked me question, how the varicose vein does it affect the chest PT? Yeah, definitely it affects the chest PT. Yeah, if you remember. Okay, Yeah, so chest PT is not only concerned with the middle body. Okay, what happens in varicose vein? We should understand that varicose vein, we say, and you know, like most of the population is confused superficial venous thrombosis as well as the deep vein thrombosis, right? So what happened in the varicose vein? The veins which are supposed to carry on the blood, and the valve supposed to be locked so that the blood doesn't come down. In this case, what happened? Valve become insufficient. So due to insufficiency, amount of blood start getting into down. That's how the blood, which is the venous blood, start breaking the valves and start coming to the subcutaneous area, which gives the purple appearance, right? That is what we say the varicose vein. Now, when we do chest PT, in general, no effect. But if it is a patient, we need to find out what was the reason of the varicose vein. Was it a weight, or was it a like insufficiency, or was it during a pregnancy it happened? So according to that, we need to plan the chest PT. But for normal person, of course, it won't be affected enough. And one more thing we'll have to find out. Has any DVT, I mean, has any DVT formed? Because, you know, if you take the Doppler test, you'll find out. So, or maybe we say that brachyradial, ABI, that index, in that we find out the pulse ratio of like upper and lower body part. In that case also we have to see. So what happened if there is an embolus formed and thrombosis formed, and during the vigorous movement, it has turned into embolus and it has come to the lungs or any vital organ that time, yeah, definitely it can create the problem. Okay, so that is how it can. Yeah, somebody asked me about dead space volume. Yeah, dead space volume, as I explained, Kalim sir, it is 166, I mean 150 ml as an average, and dead space volume of the air is the air volume which is not used in what we say respiring zone. It is only remaining in the conducting zone. So till alveoli it is there. In alveoli again it won't be there, but yeah, that's the reason I told you physiological and anatomical dead space will be same. But when it comes to the like a pathological person, lung pathology, in that case the normal physiology of the lung, where the lung, the alveoli are getting collapsed, in that case definitely the dead space will increase, because apart from that, that will be added volume of 150 ml plus some small amount inside the alveoli, which is the deep-seated alveoli which has lost its stem. Yeah, 6-minute walk test, as I told you, it is not hard and fast, but it is a customary to do 6-minute walk test. It is a customary to do. But if you see in the manual, I have written that after 3 minutes, we check all these parameters. Okay, so in 6 minutes, in general, we feel that the required amount of suboptimal required amount of parameters we want to count, we want to be counted upon are easily fetchable. 6 minutes is not too much even for the the sick person, even for the person who has come out of hospital, like last week, and it is not too much. So what happened in this case, it actually have it's a customary to create the 6-minute test so that we can come to know the parameters we want to look upon for designing our protocols in pulmonary rehabilitation. That is how the 6-minute test matters. Yeah, anybody else? Any question? Yeah, I have sent the manual. Now you can download the manual as a PDF, and with every technique, there are a lot of techniques in this, you can see. So right from the breathing to manual therapy, everything I have given. So in this case, you can go through all those. Anybody else? Any question? Otherwise, I will ask the question before we start that. Okay, I'll ask question. No problem. What do you understand by FRC? You can unmute yourself and answer. No problem. What do you understand by FRC? Anybody? No one listening? No one listening? Okay, that's cool. Functional residual capacity. Now, I just want to know what it is, basically. You can come to the gallery view and I can see everybody. Whoever wants to answer can unmute and ask me. What do you understand with this? Yeah, ERV and TV. Well, so why it is important for physiotherapist to understand this? Because I have explained you in very detail about FRC, why it is needed and all. So now it's your turn to answer. Amount of air left in after expiration. Well, that is cool. But why it is important for physio to understand this? Okay, I'll ask you a question in another way. How it is, what do you think, like FRC should be, it should be low to decrease? Could you please explain again when to follow bad lungs approval, what to do next? Yeah, definitely I'll explain, Lalit. So this is my question hour. So let me ask question, then I'll definitely explain. I have noted down your question. Yeah. So what do you think in this case? Suppose, say for example, FRC is less for a person. Okay, fine. Let us talk about a case history before we move ahead, because we have now just to demonstrate. So another 1 hour, 1 hour, 1.2 hours is there. That's it. So I'll just talk about a case history. Case history is a 35-year-old person having varicose vein, worked in coal mine for about 10 years, is not a smoker. Okay, he came to you with the symptoms of getting tired early at work, and cough and cold. So in this case, what do you think? What should be your diagnosis as well as your treatment? How will you start treatment? Is it a COPD? First of all, is it a COPD? He has a like a pale eyes and he has a weak structure. After the assessment, he has told even that he has a constipation. Do you think it's a COPD? Then what it is? Then what it is? What is SOB? You can unmute and verbally interact, no problem. Shortness of breath. Okay, cool. No, he hasn't given any history of shortness of breath. He is telling that only he is getting tired in anything. So you should have a clue that, right? Why we will get tired? Either we'll feel tough, we'll feel heavy, or we'll have a shortness of breath. Simple. So he hasn't given, right? Cool. It's a COPD, right? It's a COPD. Well, because he's constantly giving the, yes, for cough Because of muscle fatigue. Yes, completely understood now. Yes, 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 yes. Well, 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 well. Very good. Now another case history. A person coming to you. A person coming to you. His pneumectomy has been done for the right lung. Now in his X-ray, you find water is filled in the right side. Okay, he has come with the shortness of breath, muscle tiredness, and the doctor has told you to go ahead with the pulmonary rehabilitation. Come in the gallery view. I want to see everybody. So in that case, what is happening? I mean, now you find sorry, I gave you the clue anyway. So now you find in the X-ray, there is some opacity in the right side. Opacification, we say that, opacity. Why this opacity, can anybody explain? If you have learned my class very clearly in earlier 2 hours, you'll be able to tell very easily why there is an opacity in that case. I mean, why do we find opacity in the lung space which has been removed? Why it is like this? Anybody has any clue? Otherwise, I will tell you. No problem. Fistula may be formed and fluid filled. Yeah. Okay. Anybody has any clue? Any other clue? Good. Pranjali, sorry. Pranjali what? Okay. See, if you remember in my earlier class, I told you compliance, right? Lung compliance. Forget about compliance. This is my mask. Okay, let's take as a like a balloon kind of thing, right? It has some elasticity, so anything will be set compliant if it can hold the volume by increasing volume, and it can distend. So this can distend, but after some time again the volume cannot be filled. Okay, so if you take to the cup or a kind of, you know, like a small bottle kind of thing where you can fill up the water. So here you can't increase the number of volume, I mean number of ml, right? Because it is stiff. So this is what is happening in pulmonary fibrosis. Pulmonary fibrosis is a stiff structure, right? Compliance will be too low. Correct. Compliance will be too low because it cannot move further. It is a fibrosed. It is stiff. But if you come to the like a bulle side, I mean what we say atelectasis or air-filled bulle or fistula kind of stuff. In that case, what is happening? It is increasing the volume, but again it can't hold, but increasing in the volume. Okay, so in that case also compliance is too low. Now, if you talk about this lung, what is happening? If you take X-ray, the fluid has come toward the right side because there is no lung. First reason is gap, space. And how the space matters? Space matters because the chest wall, you see, now you can't expect having a chest wall pressure same for both the place. Is it true or not? Because there is a lacking of pleural pressure. So there is nothing which will hold the chest wall nicely. So what will happen? Surface tension. What will happen? Fluid anyway will come because there is a gap, so fluid has to come. But that pressure won't be equivalent to the pressure of the lung. So fluid will be there. It is because the chest wall movement will be a problem. That's the reason even these kind of people after pneumectomy, they have the not only the volume and capacities problem, they have even the restrictive issues. Isn't it? They have restrictive issues. And if you take X-ray, of course, because of water, it looks like opacification happens. So I would strongly recommend that if you can join our class for the X-ray, CT, MRI for physiotherapists, it will be of immense help to you guys. Immense help to understand the X-ray, to understand MRI. And then we have included even the orthopedic part also. We have included even the visceral part also. We have included even, of course, the lung we have included. Lung will have in detail. So, you know, by seeing lung, like today you were seeing the atelectasis part, right? Likewise, by seeing that X-ray, you can say that, yeah, it is, problem is like fibrosis. Problem is like this. Problem is like a bulle. So this is how the imaging matters for physios. Yeah, well, now with fibrosis, I remember something regarding the COVID. You know, do you know the COVID people, like COVID recovered people, many of them, they have a problem of, like they have reported back to the hospital with problem of, I can say the complication of fibrosis. Why does fibrosis happens? Anybody can say? Go to the basics. Basics of pneumonia. What happened in pneumonia after infection? Fluid will come out. Proteins will be there, right? Those proteins. Now the fluid interface is more. Suppose the 30% of part of the lung has got some fluid. How the oxygen will happen? How the oxygen transfusion will happen? It cannot happen, right? That is how the volume has gone down. That is how the pressure is getting down. That is how everything is getting down. Now what is happening? More and more fluid is coming. Yes, loss of compliance and formation of granulomatous tissues. Wonderful, Varalakshmi. Yeah, this is what is happening. So this granulomatous tissue has given me some more indication. Anyway, so that is how the capacity is decreasing. Here, the moment you remember that bronchial hygiene thing, right? You see the circle. I have made such a simple circle through the help of some books and internet, and of course, with my own ideas. So that circle, if you see that circle, whole cardiopulmonary conditions rotate through that. Plan your techniques depending upon the contracts. I mean, the condition, it will be done. Okay. So now, the moment you control the fluid, you start your oxygenation part. Start right from the diaphragmatic breathing, go for the deep, go for the pursed lip breathing, go for dissolve. So that is how you will get more and more breathing practice. And after that, go for the accessory muscle training, chest wall movement exercises, chest wall mobility exercises. And after that, standing and doing all relaxation techniques. Teach your patient the relaxation techniques. You see, teach the relaxation techniques. Like simple on the table, if you do like this, it is a relaxation technique. On the bed, if you take a pillow and then do like this, it is a relaxation technique. Even in the kitchen, if you hold yourself with a slap, that is a relaxation technique, isn't it? If you are talking, if your patient is saying like getting tired, okay, fine. If somebody coming and visiting you in the home, try to take the support of the wall and then stand. Keep keep a hand in the pocket and then stand like a hero and then speak. I mean, actor. Sorry, hero. Stand like an actor and speak. Why? Because it is for the relaxation rather than anything else. So hit at all the problems, whatever we have. Anybody else? Anybody has any other question? Because then we'll be moving ahead. Any question? Please ask your question in the chat box. I'm seeing the chat box continuously. Okay, one more question. Many of the places we have found the nurses and the paramedic staff, they have taken like azithromycin, those antibiotics by themselves without detecting any bacteria or anything, but they have taken just for a precautionary stuff. What is your opinion about it? Should they have taken? Is it needed? Just tell your answer. I'm constantly seeing the chat box. Studying like this. I think model has already come. So now we will start. So I asked the question about azithromycin. But so if it is possible, you guys can open up your book. Sorry, open up your manual, whatever I have given, and this will be too easy for you to understand that. Meanwhile, I will start demonstrating one by one. So I'm focusing my webcam on him. Can everybody see him? Can everybody see him?
Yes, sir.
Okay. Somebody said no. I'll focus some more. Check. The bullet points have been given in your this one, what we say, manual. So you can just open up your manual and see. Everybody is visible this? Visible?
No, sir, you are not visible, and I have not received any manual yet.
Check on your WhatsApp. Check on WhatsApp.
Not on WhatsApp, and not on mail also.
Just a sec.
Yeah.
Yeah, I have sent it. It has been delivered. Are you there in the WhatsApp group, ma'am?
No, sir.
You are not in WhatsApp group?
No.
Just a sec. But you had got this mail, right? This regarding the WhatsApp invite. Regarding the WhatsApp invite, you had got the mail, I believe.
WhatsApp invite. Okay, let me see.
You can just check it.
Yeah.
Because most of them have been added in the group, and I have sent the manual in the group.
No, sir. Okay. No, I haven't received any WhatsApp invite also. Okay, there is the link. Let me just join.
Just join it. No problem.
Yeah, sure. Just joined it.
Yeah. I'll finish these techniques.
For that, you have to send it again.
Yeah, I'll send it. Don't worry.
Yeah, sure. Thank you.
The moment you join, you just let me know.
Yeah, I have joined.
You have joined?
Yeah.
Okay, I'm again reposting it.
Okay.
You'll get it within seconds. I think
Got it. Thank you.
Right? Yeah. So kindly download it. Unless you download, you will not come to know. I think anyway, it will be sent again you whenever you want.
Done. It is downloaded. Yeah. And yeah.
Yes. Fine. So just keep in your hand that keep that handy, okay? Because I'll be talking in bit detail. So in that case, I'm actually monitoring that whether you guys are able to see or not. Able to see? Able to see perfectly?
Yes, sir, we can see you.
Thank you.
Yes, sir.
Yeah, thank you so much. Yeah. So those who have not received can check it from this one. What we say from this one manual. Now go to the PNF respiration. I will not share right now. Just go to the PNF respiration. Did you go PNF respiration? Go to the PNF respiration in your this one PowerPoint presentation. That PNF respiration. Everybody got that page?
Yes, sir.
Yeah. Let everybody come to that. I want you to go one by one. Then it will be easy for you to understand. Then we can finish early and better. Yeah, there is a table, right? So we have almost 7 types of PNF techniques, right? One is the perioral pressure. Everybody can see in their menu. I mean, this one. Everybody can see in their manual. Everybody can see in the manual. Perioral stretch, intercostal stretch. Then there is manual vertebral pressure high and low. Then there is co-contraction of abdomen. Then there is anterior stretch vessel lift. Then there is a maintained moderate manual pressure. Everybody can see all these 7 principles. I mean 7.
Yes,
yeah, please tell. In the manual there are 7 methods, right? So first of all is perioral stretch. Look, this is the only PNF technique where you have to give for the child. This you remember. So how do you have to do it? Just see that.
so we can see the video.
You can see the video?
We can't see, yeah.
You can't see? Okay, it will come. It will come. I have focused the webcam. It will come. Anytime it will come. Just a minute. Can you see now?
Yeah, yes, sir, yes, sir.
Yeah. Just a second. Yeah. Yeah. So what you have to do in this case, you see, your finger like this, you have to do, what is the stimulus here? You see, applying the firm pressure, okay, firm maintained pressure to the patients on upper lip, okay, upper lip, only that. So you will find what? 5 seconds of apnea, but after that epigastric excursion will be followed. Okay, so this is called perioral pressure. This works on what? This works on your primitive reflex related to sucking, breathing, and swallowing. So you have to go near the kid and you have to do like this. Okay, I'll explain you again. Increase this one and explain you. I said, keep this finger here 5 seconds, you just, okay? And then relax. I'm sure the video is coming. I have monitored it. Now the video is coming anyway. Press it 5 seconds and relax. This is the only technique you have to use for the kids. Kids, no PNF in respiration has to be used. I'm making it very, very clear. Only this is the position you have to use for the kids. Perioral pressure. There are other methods like intercostal stretch. There are manual vertebral pressure. I'll show you what it is. Lower rib, upper border of lower rib, you have to hold like this. Okay, got my point? Upper border of lower rib in downward direction, you have to do it, and then relax. You'll find the better epigastric excursion happening and respiration happening. This movement happening areas in and around the intercostal muscle. That's for sure. How it is, you see. This particular part, take it, go to the lower part of the rib and press it and relax. Press it downward and relax. That's it. Is it clear? Is it clear, everybody? It's very clearly written in the manual, table wise. I want answers. Is it clear? Saw my hand?
Yes,
Down.
sir.
How long you are holding this stretch?
We don't have to hold more than 3 seconds or 1 second or 2 seconds. Not more than maximum 5 seconds.
Okay, sir.
Got my point? Not more than 5 seconds. Basic idea is, if you see the diaphragm origin part, it is from the all round, right? Right from the G-sternum to G-fight process to lower part of rib to the lumbar vertebra. It's having a long round dome shaped muscle which is having a various origin but single insertion called the central tendon in between. So we are trying to press it like this, downward stretch we are giving, and we are waiting and then releasing. So you'll definitely find. I'm actually experimenting this in one of the head injury case right now. Okay, this is the one thing. Now, manual vertebral pressure high and low. What is happening in this? Go to the T2 and T5 region like this. You can, it depends upon your dominant hand. Okay, T2 to T5, you can palpate and just give upward direction pressure. Upward direction pressure, you see, upward direction pressure. Like this, holding for 5 seconds, relax. Lift up, holding for 5 seconds, relax. Okay. This is called the manual vertebral pressure high. And then there is something called low. Look, high and low has nothing to do with the high and low like this. No, it's a high T2 to T5. Now you will be giving to T7 to T10 like this. Okay, lift up, relax. Lift up, 5 seconds, relax. I have given the mechanism. These all work on your stretch mechanism, nothing else. It all work on your intercostal stretch receptors. You got my point? These three techniques, you got it? Huh? 4 techniques, in fact. You got it?
Sir, for lifting, you are using your body or your hand?
That question I'll answer you only when you answer my one question. What is the conservation principles of physiotherapist? I'll tell you. Look, you do any of the physiotherapy. Say, for example, I'm doing the passive movement. Okay, passive movement for him. I'm holding him, right? Right?
Okay.
Just interact, okay? You know, normally physios will do like this. Many of them, they do like this. I personally always go with the movement. I always go with the movement. You know why? Because this is called the energy conservation principle. I don't know whether anybody has told you about it or not. If you do like this, you'll be less tired over the period of the day. Got my point?
Yes, sir.
Yeah. So today onward, doing anything like this, you saw, even I was doing like this, I was not coming on him, but I was moving with my hand, right? So that works very good for the physios. So always remember that energy conservation principle. Do anything, just try to be the part of the movement. Okay, that will tire you less. Clear?
Yes, sir. Clear.
Yeah. So now co-contraction of abdomen. Co-contraction of abdomen is nothing. It is, you know, placing one hand on the lower rib and Another one on the pelvis, like this. Oh, okay, I'll show you from this side. Then one hand on the lower rib and one hand on the pelvis. So basically, we try to stretch this particular part, this very part, like this. Relax, like this. 5 seconds, relax, like this. Relax. Okay, so this is how it is giving you for the co-contraction of abdomen. At a time, you are trying to stretch your abdominal muscles, receptors. That is how. Okay. Okay, so there are something like anterior stretch basal lift. It is nothing, same thing like this. You see, go to the posterior ribs. Okay, and try to move like this. Move like this. Look, PNF in the respiration, if you find on the YouTube or the lectures or even by the neuro professors, mostly they go this technique, only this, downward and relax. And this is the most effective. But I'm telling you, go with all these small techniques for 2, 3 times, 5 times like this. This will be too good for your patients. I'm telling you, I'm giving you a return guarantee. Any unconscious patient, go for the PNF in respiration, no other. Don't be worried about it. So, very simple. The first one, then I told you about the mandibulovertebral pressure on the T3 to T5. Then I told you about the T7 to T10. Then I told you about the co-contraction of abdomen. So these all 4, 5, if you remember, that's more than enough. One more I'm telling you. Suppose the patient has got rib fracture. Say for example, I'm giving you one question. Okay. So what I'm saying you, suppose I'm giving you one case history. Suppose somebody has a rib fracture after the road traffic accident. In that case, what happened? No, there is a technique called maintain moderate manual pressure. You don't have to do anything. Go near the patient and just try to press his rib area. Got my point? Press his rib area and then relax. You will find there is an excursion happening. There is an excursion happening in that area. Just moderate pressure, 5 seconds, relax. Okay, in which phase? What do you mean by phase? Yeah, both sides. Yes, definitely both the side we have to do, Shankar. And phase I did not get. Can you be a little more clear about phase? What did you ask? Because I'm not able to understand the phase. I'm waiting for your answer. Acha, okay, that's what I wanted to tell you. Look, in these kind of people, mostly if you do it in the inspiration, there will be a problem of the resistance. So try, there is no hard and fast rule, but still try to do these pressures, start with the expiration, okay, and do for 2 to 5 seconds. So what happens, suppose I am doing the maintained moderate pressure. I'll go near that, in expression I'll find, and then I'll relax. Expression I'll do, and then I'll relax. How can you give instruction, Lalit? The patient is unconscious, no, in this case. Patient is unconscious. PNF you don't use for the normal patient. Always remember. It is only for the unconscious and bedridden. Clear? Yeah, fine. So now you can go to your PNF. I'm not sure, maybe I think the breathing exercises part will, normal techniques will start. So normal techniques, you know very well, the deep, this diaphragmatic breathing, everybody knows, right? The side lying position, semi-supine lying position. So semi-lying position and telling the patient to start keeping like this and breathe in, breathe out. So what happened? You find there is a difference of this one. This is coming, so he'll be seeing that yes, it is moving, so it's a visual feedback to the patient, right? So that is how it works. And there are other methods. Normally there are other methods that the patient is not necessary that, you know, we have learned always in our school, in the college and hospital, we are making the patient to do like this whenever he's lying. No, it's not necessary. Even he can come to the sideline and he can do the same thing. Yeah, see how nicely he is sleeping side. He'll be talking with his wife, family, everybody. And then he'll be keeping this one, and he'll be watching, he'll be watching through his tactile sensation that it is moving. Right. So even with the sideline, there is no problem. In fact, standing, I will only show you how to do standing one. You see, I'll be going near the wall. I'll be, like taking my hand like this in my pocket, and I'll be standing easily. So this here also I can see my abdomen moving. Did you get my point? So basic idea is here to make you have to have you, what we say that, intimated about your diaphragmatic movement. Okay, and this is the most basic exercise, what it has to be started. So if you go to near the patient first time, very weak patient, if you don't know how to do it, what to start with this. Start with this, and partially breathing, this is the best. Okay. So I'm sure you will have no question in diaphragmatic breathing, past many years you have been doing. So these two things came new in the diaphragmatic breathing, right? In the sideline, even on the standing. Is it clear? Has any doubt? Please tell me. Otherwise, I'll ask one question. Very simple question. Anybody has any doubt? This is digital classroom. You can talk about yourself only. No problem. Nobody is there nearby you to disturb. Anybody has any doubt? Well, then I'll have one doubt and I'll answer you the same. What I'm saying you, suppose somebody you are doing the upper limb and lower limb exercise, and then he was told to do for the like a pulmonary rehabilitation by his doctor. So in this case, when he's getting tired, rather than sitting, can't you do this? Sitting and having a normal diaphragmatic breathing exercise. Sorry, standing and having a normal, right? Or maybe he can sit and he can try on the chair itself. Like this. Isn't it true? Yeah? Clear? Next is the deep diaphragmatic breathing. It is nothing. It's just a combination of deep breathing with diaphragmatic breathing exercises. In this case, tell the patient to have long, slow, and deep breathing. That's it. Okay? But again, it is not possible by everybody. That you have to see. Most of the time, after acute exacerbation, you're not supposed to say this. Then is an end expiratory technique. Okay? So, in this case, it is, like a deep diaphragmatic breathing. You have to tell, after add up some more inspiration. You can make it in lying, you can make it in sideline, you can make it in sitting, anywhere you can make it. So when there is a region of the lung which has partial obstructed airway, okay, due to any of the problem, the alveoli always will have a go slower. Suppose he has a problem here, maybe, okay, but whatever the lung pathology is. So you can't expect the air filling is the same from this side and this side, right? Here it will be less. So in this case, what happens? We say the patient, okay, like you have a normal breathing, have a normal breathing and hold at this point, okay? Hold this point and then relax. So we cannot do this for the dyspnea patients, of course, but for the patient whom you want to increase the volume part, you definitely can go for it. Now you can remember the physiology of interdependence, or you can remember the physiology where the air was going from one corner, like channel of Lambert, channel of Martin, pores of Kohn. Okay, if pores of Kohn is blocked, it will go through the channel of Martin, it will go through the channel of Lambert. So if you remember, I told you earlier, if you know those concepts well, it will be very easy for you. Now next is a sniff. It's a very simple and effective technique to increase the diaphragmatic excursion, but you should do this generally with the diaphragmatic exercise. Frequently, fairly speaking, if you do the deep diaphragmatic exercise, the sniff is the best. How? It actually augments the collateral circulation. Like this, you see. He can sit and do, but let him do. So how? Normal diaphragmatic breathing. Then he will do at end 3 times sniff. See, 3 times sniff. At the end, he'll be able to relax and then exhale all the air. Okay, all the air. So what is happening here? It is working again the physiology of interdependence. Okay, and then other thing is what happening here. He will have better relaxation. So suppose he's a very anxiety people. He's working in somewhere in a very severe position of marketing. He has a lot of anxiety. He has some COPD kind of. So in that case, what is happening? No, respiratory rate increases, right? Because of the shallow breathing, you have more respiratory rate to compensate that tidal volume. So in this case, I can decrease his respiratory rate to increase the volume or to maintain the same volume. So always remember, having more respiratory rate is not good. Okay, that says the story of shallow breathing. Now, next is the segmental exercise. Segmental exercise generally, why it is permitted? You know, somebody told that time pulmonary fibrosis. I'll tell that it's a chest wall deformities. Mostly chest wall fibrosis, pain and muscle guarding after surgery generally, you know, and then pneumonia. In that cases, even the atelectasis cases, post-atelectasis, we need to do that. Here, the segmentation can be, you know, like a, why it is so important? Because, you know, it could be a, like somewhere it will be a drop of transpulmonary pressure gradient, okay? And even the like intrapulmonary pressure, which is not able to let the lung getting into a better expansion. So manual cues you can apply on the chest wall and it can help him to have better expansion. So you have learned in your class in second year only, apical, lateral and posterior. Okay. So in this case, what do you do that? What do you do that? Anybody can tell? What do you do that? Nobody can tell. Look, we will tell patient, just breathe in, take some more breathe in, and we will hold this. Suppose I am showing you for the posterior, okay? So I'll be doing what? I'll squeeze his lung, and at end of expiration, I'll go down, and during inspiration, I'll give 1, 2, 3, 4 stretches downward and laterally. Got it? Downward and laterally. So downward and laterally. That I'll be giving. So that will further stress on his segment. This you can do even for the apical. This you can do for the lateral. That you can do even for the posterior. Okay? All three. But the technique will be same. What is the technique? Squeeze the chest. Squeeze the chest during expiration. Okay? And allow the inspiration to occur normally. At end of the inspiration, when he is almost finishing his inspiration, apply a stretch of just gentle 3, 4 gentle stretches downward and posteriorly. You see, he'll have better excursion of the lung as well as the diaphragm. So this is generally very, very important for the segmental exercises. Very, very important, especially of the chest wall deformities or any of the deformities like pneumonia and all, where actually there are chances of hypoventilation. Yeah. Next is the stacked breathing. I'll tell you, stacked breathing, if you learn, this is too great for you in your practice. Reason behind, it is the only breathing, okay, it is the only breathing where you have to have more inspiration, like what we say, effort. Okay, so you have to tell the patient to breathe 3-4 times. Okay, see, 1, 2, 3, 4 times he has taken the this one. So he has stacked his breathing, right? So now it is a extra volume of air in his lung. So what will happen now? What will happen now? So we will tell him to expire all the air at a time. Okay, to keep the means I mean that only 3-4 times in such a way that he should not have cough. That is also important. But you should have more inspiratory effort. Then slowly he has to expel all the air out of the lung. Whatever he can do. Okay. So here you have two benefits. First is your inspiratory muscles are getting into exercise, and second thing is what your glottis, because glottis will be closing the air after tidal volume every part 1, 2, 3. So it will build up the air. So in this case, laryngeal control also will be too good. Fine. Then there is something called the slow maximal inspiration. Okay, so we say slow maximal inspiration basically good for longer, you can say like RTA cases where they have everything intact, like brain, spinal cord, everything is okay, but only thing that there are a lot of limb injuries. Maybe there are multiple fractures in the limb. So in that case, what do we say them? You keep inspiring. Yeah, so you see, he's slowly inspiring. He has built up the good air. Now slowly I'll tell him to expire. Okay, so this is the slow maximal inspiration. There is something called sustained maximal. All of you are using, just one sec. Yeah, all of you are using spirometry. True. So in spirometry, what is happening? We are taking breathe and then try to tell the patient to hold, or if it is not hold, just try to relax in between the two spirometry. So what is happening here? Okay, what is happening here? It is actually again the deep, slow, long inhalation, okay, from FRC level up to the total lung capacity. So always remember. So tell the patient to breathe in first, then breathe out. See, he has left almost till his FRC level. From his level, he's taking the whole breath in, total lung capacity. Then he'll be again relaxing it. So what is happening here? In this case, it is like total lung capacity. That means what? It is recruiting most of the lung. It is actually what we say. It is like having a lot of effort on even the necessary as well as the accessory muscle everywhere. That is how the sustained maximal respiration is important. So sustained maximal inspiration, you must go for the patients who are having a better stability, and then they can do it from FRC up to the total lung capacity, followed by 5 to 10 seconds of breath hold. So unless they are holding the breath, there is no use, because if they hold the breath, there is an interdependence things. You remember in the concept I told you, physiological interdependence, it will go differently to the different alveoli. Okay. Next is glossopharyngeal breathing. Glossopharyngeal breathing, generally, suppose somebody has a C3, C4, high level of cervical injury. In that case, we tell them to have this glossopharyngeal injury. See, in that case, what is happening? He is with severe weakness of the muscles of like a diaphragm as well as this. So in this case, technique, we can say in this technique, he will take different gulp of air like this. See, he's able to take several gulp of air. Okay, so say for example, each gulp some 100 ml air, not more than that. So he'll be able to after 6, 7, he'll be able to, say for example, 50 ml of gulp. So after 5, 6 times, he'll be able to make a planned tidal volume. That's how the whole idea behind it. And after that, it will be released. Okay. So it increases tidal volume, no doubt. It increases depth of inspiration slowly. It will increase even the total lung capacity. Most importantly, the vital capacity. Then after that, abdominal breathing. Should we explain abdominal breathing a little later so that we can finish other things? And then, okay, let us talk about abdominal breathing again. No problem. Abdominal breathing, you know, this is exercise where the abdomen is into the picture. But as a technical person, you must always remember that this is the only breathing where the expiration matters most. Okay, expiration happens before inspiration. Okay, so those who are paralyzed or having abdominal or accessory muscle strength, okay, the procedure includes what? Contraction of abdomen. Yeah, contraction of abdomen. And after that, if contraction of abdomen. So what is happening if he is doing contraction of abdomen? It will push up the diaphragm, right? Right? So what is the beauty here? Beauty is before he takes the breathing in, okay, already he has a diaphragm built up. So when he takes the breathing in, it will have a more, the diaphragm will be having a like a already support from the abdomen. So diaphragm will be having a better dome placed. Okay. So in this case, his tidal volume will be much bigger. Okay. So if anybody asks you, or for your understanding, just keep in the mind, following the tight, like what we say, sorry, after doing the contraction of abdomen, anybody, what is happening here? Pressure of the abdomen pushes diaphragm. Okay. So if it is already pushed, look what is happening now. In normal patient, diaphragm is a normal thing, like a patient. Okay. So if there is a contraction, good abdomen in this. Okay, just 1 minute, be on call. Just a minute. Just 1 minute, be online. I'm coming. sorry, there was a disturbance. So in this case, already abdomen, which is having a pressure, so it will push already. Yeah, it will push the abdomen already at one level. Okay, so when there is a already inspiration happening, that time diaphragm can have a better built up to have accommodate more air. That is the most important reason. So I told him to contract your abdomen, then you start breathing in so that you have more breathing capacity. That is how it all works. Now, there is something called air shift breathing. It's one of the most important maneuver, air shift maneuver. Able to hear me? Air shift maneuver. So air yeah. Uh, it is an air shift maneuver. In this, what happens? Suppose somebody has a accident, good abdomen even after the accident. So we say what? You try to contract your abdomen, and after that you breathe in, relax. So why do we say breathe in and hold? Reason behind, I'll tell you. Being on the bed for a long time, only the pump handle movements remain, but the bucket handle movement, it get lost. In this case, what is happening? I told the patient to contract the abdomen, and after that, after taking a good breathing amount, hold the breath, and then contract and relax your abdomen. Okay, it contract and relax your abdomen. Okay, so it can contract, like almost till 2 inches. So what is happening if he is contracting and relaxing by holding the breath? So the air in the chest, this rib cage in the lung, will not go only up, it will go even the side, right? So it will open up the new space which has lost over the period of years. Did you get my point? So please use air shift maneuver for most of the high level of cervical injuries where they have a good abdomen, but they have a lack of breathing. In that case, as I told you, close the glottis. Take a deep breath and start contracting the abdomen. And in that case, glottis will be closed. So what is happening here? Not just pump handle movement will work, even the bucket handle will work. So that is how it will open up the chest valve better. So chest mobility and belt exercises, we can do it also. Chest mobilization exercises is the next something you can find in your manual. I have given beautifully. This combine active movements of the trunk or extremities with the deep breathing. Okay, so generally these exercises we are doing in the pleural disorders. Okay, pleurisy or pneumothorax, and that case, but only after the intercostal tubes get removed. We cannot do all those exercises when there is a what we say tube is there. As I told you, the bad lung up rule. Again, I'll explain you later. In this case, let us talk about the chest mobility exercise, which is very, very important for the physio. So either sitting or standing. Okay, so So in this case, starting position, how it is? Starting position will be, suppose tight side is to lengthen, like how? You have to lengthen the tight side to tight structures to expand that side of the chest during the inspiration. In this case, what happened? Suppose we are performing on this side. I will not tell left or right because you may get confused in the Zoom because what you are seeing could be different. Okay, so suppose this side we are trying to do chest mobility exercise. So opposite side, keeping like this or maybe like this, patient can bend like this. Side bend like this, he can bend. Okay, now he can easily keep a like a better to make a fist. Better to make a fist like this, okay, and then he can bend toward the tight side and breathe out during the expiration. I mean to say like this, breathe in and the breathe out during the this side. Why did we do this? This side is a tight side, so he has done nicely. He has fulfilled the air and then he has tried to press and then take a breath out. Now, suppose you want to progress this exercise. You can make the patient stand, or you want to progress some more. Tell the patient to go further like this. Okay? Okay, got my point? So, this will put an additional filling of air. And while suppose he is going that side, in that case, you can tell the patient to raise the arm. So that will fill up more air. Likewise. And then again, he can put a fist and then he can come back like this. So this is how you can progress your exercise. So it is for the one side when you do it. But upper side and stretching the pectoralis muscle will not go so simple like this. In that case, he has to keep like this. I'll focus on him. Yeah, like this. Okay. So, yeah, come down like this. So in this case, what is happening? Yeah, he will be moving like this. So here in this case, he'll have a deep inspiration. Again, deeply he has to, like this, he has to do expiration. After doing for 5 or 6 times, then he can do like this inspiration. Then after that, he can come like this expiration. Yeah, like this. Okay. So use your elbow like this. Expiration. So whenever the thorax is coming closer to the leg, expiration will happen. Well, now suppose this was for the pectoralis. Suppose you want to move the upper chest and shoulders. In that case, I already told you, you can use the arms like this. Same like this. In and then out. Very simple exercise. And after that, in the progression part, we can make the patient stand and progress. Then, suppose somebody is very weak, is still not able to do that, what to do? In that case, lying down and pulling the leg. Pulling the leg always should be below the knee. Okay, what we say the hook lying position. Very, very important. Okay, now I will show you something kind of wand exercise. Okay, how to do the wand exercise? Very, very simple. You can do look, he has a wand in his hand. He can stand. Yeah. So in this case, nothing. Inspire and take the wand up. Expire and take the wand down. Either he can also come down, or if he is not comfortable, he can take wand up and then he can bring the wand down. So in the sitting as well as the standing, both is common. Now, suppose somebody wants to develop shoulder after COPD acceleration and then weakness of the accessory muscle. In that case, very simple. Internal rotation, external rotation. Internal rotation, external rotation. With the wand also, you can do wonderful things. Now, apart from that, if you have something called the sides, just one sec. Suppose he has to do for the sides. How will he? Either he can use any belt, beautiful belts are coming, or in my opinion, it's always good to do with the rolled bed sit. Okay. So first we will be talking about the unilateral posterior basal exercise. In that case, what is happening? You see. Okay. So one hand he can keep it like this, or he can just hold like this. One hand. Now the most important for a physio to understand the direction. Okay. So it is for the posterior basal expansion exercise, unilateral. In that case, what will happen? The one end of the bed, like a towel, I have just fixed it here. Another end is there in his hand. So what is happening here? Now, forward direction. Okay. Since it is for the posterior basal, always remember it will go to the forward direction. Forward direction. How? Now he'll be breathing in. Breathe in. Breathe out. So while breathing out, his hand will be, direction will be forward. But when it is a lateral basal exercise, his direction will be diagonal. That is the angle of pull you should remember as a physio, nothing else. Okay, forward for the posterior basal, down this what we say that lateral basal. We have to do it for the laterally we have to go for the diagonally we have to go for the lateral basal posteriorly. If you have to do for both the hand, both the sides, suppose both the side has to be exercised, in that case he has to go diagonally like this, this would be the force. So he has to inspire like this. Got my point? See, look at here. Look at here, how nicely. So this is how it has to be done. So this is how the belt, if it is not belt available, you can use the bed sit, no problem at all. It's 100% accepted. Okay. So this is how it will suffice our chest mobility and belt this one exercise. So next is your ACBT. Okay, ACBT. So ACBT, let us talk about ACBT in bit detail. Okay, what is ACBT? Anybody can tell in a very simple manner? Simple manner I want. It's there already in your manual. I want in the simple manner. Okay, before ACBT, let us talk about forced expiratory technique. I think that will be easy for you to understand. What is forced expiratory technique? Anybody? Anybody? It is a forced expiration or huff combined with the periods of breathing control, 1 or 2 huff from mid lung volume to low lung volume. Simple, very, very simple. You have been studying from the second year. Now, how to use this FET technique in normal this one. So see, he will be showing you the forced expiration technique. Simple, forced expiratory technique. But here, forced expiratory technique, apart from that, ACBT is some of the one of the most important thing. Why? Because active cycle of breathing technique. In this, we'll have a definitely 3 phase: breathing control, thoracic expansion phase, and the forced expiratory technique. So breathing control is why it is needed. Breathing control, always believe that you have to do it with the diaphragm. Yeah, wonderful. So breathing control has to be done with the diaphragmatic breathing. Simple. No other breathing has to be done. Just simply for 3 to 4 times you'll have a breathing control. Yeah. See how nicely he's doing, slowly, slowly. And then after that, next phase is chest expansion. He'll have a chest expansion. How? Doing the deep breathing in, so that he can have a what we say that IRV, inspiratory reserve volume maximum. Now the expression is passive, right? So what you can do, you can use your chest percussion or vibration that will be performed in the thoracic expansion. Why? Suppose he is doing that and I'll be doing this. You can add this also. There is no problem. Absolutely, you can add it. And after that, you have to tell the patient, you breathe in, forced expiratory technique. The third phase you have to come. Okay. So it is what, as you told, forced expiration or huff combined with periods of breathing control. Simple. So in this case, use two kind of huff. I'll come to the cough and huff, but use two kind of huff. Everybody of you know that. What is mid lung volume and low lung volume? So why do we use that two kind of this? Because it will mobilize the secretion. Okay. I have told you equal point of pressure. If you want, again, I'll explain you at last after the model goes. Okay. In this case, what is happening? If he has having a what we say mid lung volume, okay, then it is supposed to clear the secretions from the alveoli, and then it comes to the bronchiole. But when it has a low lung volume, okay, like huff will be more longer and it will be quieter. Always remember. So huff after the deep breath will be effective to clear secretion, because the secretion will come to the proximal airways from the distal. So high lung volume cough, huff. See, high lung volume huff, always do minimum 2. That will be very, very good for clearing the secretion from the main bronchus. Now the thing is, like for normal patient, it is okay. Normal person, it is absolutely fine. But for the patient, it can have some spasm, bronchospasm. So what will you do? That is where your breathing control comes into the picture. So breathing control, I have seen students taking very light, only 2 times the no, very bad. Breathing control is very, very important. Don't take it light. In between, even in between, I have given a sequence also. You can just see that in that sequence, what is happening now after thoracic expansion, you can again add up the breathing control. There is no hard and fast rule. You can definitely add up the breathing control. In that case, after that, again, you go for the low huff, then you go for the, again, you can go for the breathing control, no problem. Again, you go for the high huff, then again, from there, you go for the forced expiratory technique. So, yes. Now, after this ACBT, you have something called the autogenic drainage. See what is happening in autogenic drainage. Again, if you remember what I said, you will be able to frame your things very clearly. Autogenic drainage, it is I have given in the manual, it's a 2 approach. One is a Belgian, one is a German. Belgian is a 3 phase, German doesn't have any phase. Okay, but here we always say patient to have a normal breathing, and after that have, it has 3 phases. Every one of us know, unsticking, collecting, evacuating. But what is this? How it is important? 3 phases are fine, but why it is important? How it is important? So first phase, as I say, is the unsticking phase. In this phase, increased respiration by deep expiration. Okay. Then what happened? The mid-tidal volume, that will be lowered in the range of normal ERV. Okay. Always remember, it will be normal in ERV. That is what is the unsticking phase is concerned. In this case, after the, okay, normal breathing, you see that. Normal breathing, this is tidal volume. Now, see, he has come to the ERV. Now, for 2-3 breaths, I'll tell him from the ERV to take little bit, mid-tidal volume. Mid-tidal volume he is doing. Okay, this is the unsticking phase. After that, in collecting phase, he has to change gradually from the expiratory reserve volume to inspiratory reserve volume. That is how the mobilizing of secretion from the apical region it happens. Okay, and longer the expiration, greater the distance of secretion will be moved. So always remember this particular point. Why? Because tidal volume breathing in the So it will be moved from the apical region. Okay. Now at last is evacuating this one. So how will you bring to the mouth? The patient in this phase, patient has to what? Increase the respiratory flow from level. Okay. which is level about the middle of the inspiratory reserve, added by short burst of general coughing. So means now he'll be flowing like this. So after doing for 3 times, you see he got cough, so he'll be taking out. So in this phase, generally what happened, it increases the respiratory flow starting from the level at about the middle of inspiratory reserve capacity, which was attained in the last phase, and then added by short cough. I mean, cough is always good if it comes in this case. Okay. Autogenic drainage, don't try anybody below, especially for the, anybody you don't try below 12 years. It's my personal request to you, because it is not possible to do. And, like beauty of this is you don't need to do any PD positions. Okay. So, so it's very good for the most of the patients, because you don't need to do any PD positions for this. I mean, the postural drainage positions. And other thing is like, don't try for the children, better avoid it. And anybody has a language difficulty with your patient in your hospital, don't try ever this autogenic drainage, because this is something very, very bit more complicated to understand. Though for physios, it is most easy to do. Now, some of the obstructive disorders we'll talk. Okay, sorry. Breathing for the obstructive disorders. How? First one, as you know, the breathing control technique. Okay. Breathing control technique, just now you have seen, it is, done with the diaphragmatic breathing. It is only to prevent the, what we say, dyspnea or bronchospasm, the most important. Other is pursed lip breathing. You know very well. Yeah, see, pursed lip breathing. This is very, very important. It stresses on expression. Therefore, it can be used to control breathlessness and to reduce the work of breathing. It keeps airway open by creating back pressure in the airways. So how to do it? How to do it? In this case, how he has kept his lip, no, like a purse. He has to purse his lip like this, and then he has to increase the. He has to. He has to exhale through that pursed lip. Okay, so what is happening in this? Do you know about PEP, positive and expiratory pressure? When we'll be talking about that, that is very important. PEP is very important. When he's taking out the air like this, there is a vibration going back. Okay, so that is creating vibration in the lung, and that is where the pursed lip breathing is one of the most important breathing in case of dyspnea, in case of spinal injuries, in case of anybody who is not able to do the advanced breathing. There is something called Innocenti technique. Now, Innocenti technique, I don't have that apparatus, otherwise I would have shown you. It actually prevents forceful expression. That is the reason it is less energy consuming. Here, what happened? Each breath patient, you have to instruct the patient to take breathing normally before the abdomen come into the picture. Okay, so here what is happening? Breathing in, breathing out, and just below the tidal volume. So this is what it is, even less energy consuming than the than the pursed lip breathing. Why was it needed to have a less energy consuming? Only because suppose he is very weak, then in that case tidal volume may tire him. So in that case, before the abdomen come into the picture, you have to instruct the patient. So your patient and your coordination should be too good. Now there is something called Buteyko breathing. Nothing. In this case, what you happen, what you do, the same patient for the same procedure, make him in the sideline and put a plastic tape, put a paper tape on his mouth. You know why? Because we want him to continue the level of carbon dioxide little up in the body. Can anybody tell me what happens if there is a CO2 higher? Okay. There will be acidosis, right? So it will create more rate and depth of oxygen, right? That is how it is important. This technique it lessens the need for medication and prevent mostly asthma attack because of this, because it creates the high level of CO2 that is important in that helps for your bronchodilation, correct. Now, in this case, what happened? suppose somebody has anxiety, suppose acute attack of asthma. In that case, what will happen? Fear and anxiety will be there. So FRC will not be attended. So stressed respiratory exercises has to be given to this subject. Okay. So you have here different type: high volume, high velocity, or low volume, high velocity, or low volume, low velocity. So I have divided in 3-4 types for your easiness. You can just go through that. What we say that to your manual. In that, pacing is a technique. Okay. Pacing, what do we do? Pacing is the technique where breathing is coordinated with the normal activity. Suppose he has this side, he had a like a intercostal drainage. So what I'll do, I'll tell him to, even in the later phase when we will be taking his upper limb exercises, I'll be telling him to increase. You have breathing when you lift up your arm. When you lift up your arm, you have breathing in, and then breathe out when you come down. So this is something to reduce the dyspnea during the activity. So he's suppose 2 steps breathing in, 4 steps breathing out. So all those things has to be taught to the patient. Okay. Exhale with effort. There is one more technique, but I will tell you to focus on the next what I'm trying to tell you. Better, that will be easy for you to understand that. There are inspiratory muscle training, inspiratory muscle training, but I'll tell you the most important muscle training is there are methods where you can have a 60% endurance for the like maximum inspiratory capacity. Give him a blower, he'll be blowing in and blow out. All those things are there, but I want you to concentrate on only one very important part, is diaphragmatic muscle training. So what you have to do in the diaphragmatic muscle training, in this you can use something, some weight or something which is like some, just a second. Say for example, this is for 5 kg. Okay, so I'll be using this. Okay, I'll be using this. This is a 5 kg thing. I'll be using on his exactly at epigastric region. Okay, little away, little down from that, and I'll be telling him to breathe in and breathe out. So subject who all are neurologically impaired, you can start easily with the 5 pound, no problem. So what is happening here? Against this weight, against the gravity, his diaphragm is struggling, right? So if he is out of the weight, then he has no struggle, right? His breathing capacity will be much better. Isn't it true? Isn't it true? So just placing a weight of 5 pound can be done like this. But in case here you have a check, you have to check his sternocleidomastoid muscle. If his sternocleidomastoid muscle pops out, then it says that a lot of accessory muscle activities are going on. So please reduce the weight. Then you can go with the lesser weight. Okay, so this is the only one diaphragmatic muscle strengthening technique. If you know, that's more than enough most of the time. So how can you go for administrating? Because I had told you almost about 15 to 20 types of general breathing exercise. So in that case, how will you decide where to use what? You can go for the assessment, you assess the condition, and then you can prepare for the breathing exercises. What kind of breathing exercises you need? Maybe you could use the nebulization, humidification, and positioning, of course, and then postal drainage also many a times. Then you can go for the choice of breathing pattern. You see, anybody is having acute asthma, this one, you have to just, I told you in the positioning, you can just place a towel roll here. That will be easy for anybody. Okay. So in that case, you go with the starting position and then start your breathing pattern. Suppose somebody has a acute asthma thing, you don't go anything except the pursed lip breathing as well as the Butiko breathing. Okay. So that is how you choose your breathing techniques depending upon the case. Now, suppose somebody is neurologically damaged but having a very good abdomen, you can go for the air shift maneuver. I told you that's the best maneuver for air shift for the neurologically impaired people. Or somebody has a high spinal cord injury. In that case, you have to go for the pursed lip breathing, or you have to go for the glossopharyngeal breathing. So it depends upon what your patient demands. So I told you how much ever the data you have, that much better for you it becomes. Okay. So with this. Like this is how the breathing capacity, breathing things I told you. There is something called flutter. I'll show you that image also later, flutter. Now the most important is cuffing techniques. Okay, I'll show you the cuffing, huffing also I'll show you. And after that we'll go for the manual things, then the model things will be finished. So cuffing techniques are first you should know what all the techniques of, what all the stages of coughing. Okay, coughing is 100% an expiratory effort with a closed glottis. Always remember. But in huffing, it's an open glottis. So stages of coughing is what? Deep inspiration, closure of glottis, forceful contraction of abdominal muscle, and opening of glottis and forceful exhalation. So first stage, how do you go for that? How do you prepare? Okay, or how do you evaluate every stage? Okay, so look for the spontaneous inspiration. Okay, use of trunk movement as extension of neck and upper GA. For normal person, I'll show you. Okay, see. So you have to see his upward gaze. You have to see his eyes. Eyes always should have an upward gaze. Always good. Okay, and then make sure that he's having a better trunk and this extension. So this part is extended enough. Then second stage, glottis closure to be evaluated. How will you know? Can anybody tell how will you know the glottis is closed or not? Very simple. Tell the patient to hold its breath. No cough. So there is a glottis closed. Okay. Then the patient knows how to close the glottis. Yeah, good. So stage 3, how do you evaluate? Okay. Active contraction of abdominal muscle has to be observed, but how will you evaluate? So cough, throaty cough indicates cough is with the inadequate force. Simple. Then during expulsion, fourth stage I'm talking about, during expulsion, does the patient appear to gag before stressfully allowing the air to exhale? Has to be noted. So there should not be any gag. Now, instruction. How will you instruct? Stage 1, you have to instruct the patient. I'll be instructing from the far, you see how to instruct. Okay. Stage 1. Okay, use your verbal cues and positioning. Okay, tell the patient, look upward and inhale. Raise both arms up and then squeeze your shoulder back. Squeeze your shoulder back. Okay, while you inhale, extend your back to inhale. See, if he's weak, he can do like this, or if he can do like this also. Okay, then second stage, of course, as I told you, the glottis closure is essential. The third stage is forceful contraction of abdomen. So he'll be having a very good breathe in. See how nicely. So this particular things all are, this all particular things, whatever we did, these all are the adapts. Okay. So this is the normal for normal person. Now you have a coughing techniques. This was a technique you have learned in class and all everything. Okay. Now, how do we go for the different techniques with a different patient? So you have a 3 types of technique: active coughing technique, assisted coughing technique, and passive technique. Okay. So in this case, active coughing technique is double cuffing. Means he will not lift up the arm, but you see, as a normal patient, how will he do it? He'll keep it like this. Okay. So he has to deep inspire. So this is the double cuffing. Okay. Now there is something called controlled cuffing. How to do it? In this case, he has to take 3 times deep breath like this. Like this, I say. So this is very good for atelectasis case. So first 2 times you are decreasing the atelectasis portion, and then third time you are increasing the volume of cough. So 3 deep breath and then cough it. So you have a controlled coughing, you can see in your manual. Then there is something called pump coughing. Okay. Here the patient takes deep breaths and then give 3 short easy cough followed by 3 huff. Like how? You see. Three easy cough. After that, he'll do what? At last, it will be a puff. So, series of 3 cuffs. This is also the active cough technique. I've seen patient being most benefited only when they have the post-operative patient are the very good improvement with this cough. How to do it? Patient will take a small breath. Okay, give a fair cough. Okay, okay, so he'll be taking a small breath, normal cough, little better cough, and then higher cough. So this is how this technique, the series of 3 coughs, please use for your patients. Okay, it is the most, I can tell you, the one of the most good thing you can do the second or third day only you can start. Now next is passive coughing techniques. So before that, let us talk about assisted coughing assisted coughing techniques. Okay, because passive anyway we don't have to do anything. In that passive, I have given different things: hydration with warm water, suction effort, tracheal tickle. So if you put a tracheal tickle, means if somebody has a trachea in the tracheostomy like this, if you suppose oxygen tube has come out and then again if you are putting it back, it will have cough. So that is called tracheal tickle. Assisted coughing techniques, you have 2 types. You have a manually assisted, you have a self-assisted. Manually assisted is something the like where the therapist has to do this, and this first is I will tell you about the costophrenic assist. Okay, either sitting or sideline. In this case, what happened? His hands should be on the. His hand should you can put it like this. That's always good position for the patient. Okay, and then therapist costophrenic angle. Okay, costophrenic angle. Right? Yeah. So hand will be kept as costophrenic angle. Tell the patient to deep breathe in, breathe out. That time you give downward stretch. Okay. So what are you doing? You are trying to increase the abdominal pressure, the stage 3, so that he can cough. So in that case, he can keep his hand like this, or he can keep his hand behind, but your hand should be like this. Okay. So breathe in, breathe out. So downward, don't go into the abdomen. That is not has to. Downward stretch you have to give, downward stretch, so that you are actually increasing the abdominal pressure to get the better cough. You are assisting, always remember. Then there is something called Heimlich type or abdominal thrust. In this case also you can make the patient sideline. There is no problem in this, but it is extremely uncomfortable for the patient. That I will tell you why, because it is abrupt nature. Okay, but here there's no problem. You can do it Heimlich. In this case, Heimlich type, heel of your hand. Okay, yeah, breathe in. So while breathing in, you have to use your heel of the hand. Okay, okay. At navel of the patient, you can see navel of the patient, up and in. So I'm going up and in toward the diaphragm. Okay, so breathe in, breathe out. So I'm assisting so that he can check out his secretions. Okay, then there is something called anterior chest compression assist. Okay, both upper and lower anterior chest. Okay, upper and lower anterior chest. During the coughing, you have to hold and you have to do it. How? You need to understand here, direction of force here will be 2. See, in this case, I'm actually on the wrong side. Otherwise, I could have shown you better. Upper and lower. Okay. So one, both will go back, no doubt. One will come downward. I think somebody has a question. I personally believe that sideline is always good, because if it is a sideline, it is an easy secretion. Okay, yeah, Heimlich maneuver. Even in this maneuver, forget about this. I'm talking about Heimlich maneuver. You can go with the side. Here you can do upper and lower chest downward like this. One will go, one will go like this, one will go like this, performing the letter V. So one will down and back on the upper chest, down and back on the upper chest, up and back on the lower chest. Okay, so this is something is very, very important. Always go into the sideline. These all things always remember, because it is very, very important to do a sideline. The reason only behind, because we want him to have a secretion better to come out. Now there is something called counter rotation. You can see this is also very, very important. Here like this. So your hand should move like a V, like a V. How? You see here I'm holding a shoulder, I'm holding his pelvis. Breathe in, Baba. Breathe out. So I am actually rotating it, right? Rotating it. Breathe out and rotating it. If you learn about the PNF, how do we do this scapular elevation, posterior, anterior rotation and scapular elevation, then this hip, how it goes like a pelvic rotation. In the PNF chapter, you will come to know this better. So for this kind of patient, we'll be finding him like this. Okay. So breathe in like this, breathe out. So while doing like this, you know, a scapular rotation and pelvic at a time. So this is closing the gap. This is closing the gap, increasing the abdominal pressure, and and this will come out. So breathe in, breathe out. Okay. So this is the anterior rotation. Now next, something is the self-assisted technique. So prone on elbow, head flexion, self-assisted cuff. You see how? Okay, so in this case, I'll focus the webcam even better. You can see that. In this case, what is happening? Yeah, he'll be looking up and he'll be inhaling more. And then he'll be looking down and he'll be forcefully exhaling. So that is how, so he'll be completely flexing this neck while exhaling. So there is a possibility that cough will come. Okay, you can use this for the paraplegia and all those cases. Okay, so this is one of the self-assisted technique I'm telling you. It may not be competing the need of the patient. Then there is something called long sitting. Just 1 minute. I'll show you in the long sitting also it is possible. You must teach your paraplegia patients whenever you meet, or stroke patients also you can. Those who have a living difficulty. Here, very simple. Okay, his hands are fine, right? So, now breathe out and he'll bring like this. You see, like this. Okay, breathe out and he'll be able to cough. Breathe out. Yeah. Now, in this case, even the patient can keep like this. Breathe in. Breathe out. In this case, he can use his own thing to go for coughing. So short sitting, same thing has to be done. Suppose he's on the chair or wheelchair, anything where the leg is bending. In that case, he can do like this. What? Suppose I'm sitting on the chair. I'm sitting on the chair. Like this. Okay. So now, next is the short sitting, hand knees rocking self knee. This is something for the paraplegia. So in this case, okay, he can come like this. Okay. So you know, he'll be able to breathe in, breathe out. Breathe in, breathe out. Sorry, I got it. Breathe in, yeah, from here. Breathe in, breathe out. So this is the least used one. This is the least used one. Just I told you one. This also can be done. It is a rocking forward and looking up, and then he can of course breathe in and then go to the fully extended posture. But after that, he has to come back, or she has to come back and then quickly rock backward, and here with the flexed head and neck, there will be possibility that cough will come. So spotty weakness like some of the spinal cord injury and Parkinson disease or multiple sclerosis or cerebral palsy, spina bifida, all those people, you can try this, no problem. So these all techniques you can try for your patients who has neuromuscular weakness or who has been a old case of pulmonary issues. You must try these all coughing techniques that will help them building better coughing attitude so that they'll be able to clear their secretions very nicely. Now splinting, splinting is very important, okay? During the coughing, splinting is the most important, but I always say there are many methods of splinting, okay? So like in case of abdominal surgeries, self-assisted means simple. Like this. Always good if we hold like this, okay? For a laparotomy incision, patient should be in a high sitting position, okay? Then you do what? You go behind the patient, okay? Take a towel in that case, and then when you are making him cough, go behind the patient. I can't go because of space issue, okay? And then hold this. Suppose there is a laparotomy incision, you hold it, and then tell him to cough, okay? This is the most important. Self-assistant means, as I told you, with a pillow or with a rolled towel, he can try that. In case of thoracotomy, what is the most important thing to be told, okay? If I am assisting, I'll be assisting like this. Suppose this side is surgery, I'll be assisting like this, okay? Okay, so this is how always it has to be like I'm talking about holding the self-assisted method is placing the hand by patient's self on the unaffected side as far round and affected ribs as possible. Apply firm pressure with the hand and forearm. So likewise, he can actually try by himself also, and then cough. So it will be very, very simple to do that. Otherwise, beer bug hold, what you say, anterior and posterior aspect of affected side of thorax, okay? It can be supported with the hands, but only when you go back. And then at the same time, forearm will stabilize the whole chest, creating a beer bug hold like this, okay? Complete support. Then he can take his hands up and then breathe in, breathe in and breathe out like that. So beer bug hold is the one of the easy thing you can carry on. In case of sternotomy, you see, like both the hands you can put it here. In that case, a small pillow, you can give a small pillow or cushion, anything. But therapist, if therapist has to do, suppose I'm having a left hand dominant, I'll do first any kind of case, like if therapist has to do, the dominant hand should come first and then non-dominant hand. So this is how about the coughing. Now let us talk about there is something called manual therapy. Okay, after this we are almost done. Postural drainage. Oh, I don't have that sort of bed, but I will definitely send you that. The easiest method of postural drainage. I'll send you the positions, and if possible, I'll edit the video. Give me a week time. That is my video only on the other patient. So there in the bare body, I have shown the different positions. So that will be helpful for you to understand. But I will check it if I can give you that position. You can correlate with that video and then your manual also. So today now we will go with that mobilization. I mean the manual therapy in cardiorespiratory disorder. Please learn it because, you know, after the COVID hit the world, manual therapy in respiratory disorder became more popular. I'm telling you, I saw some of the news articles in UK where actually it is helping for the patient coming out of the COVID ward and then having some of the like pulmonary fibrosis, and that is helping for the patient. So please learn it. So we'll have some 6, 7 or maybe 8, 9 or maybe close to 10 kind of mobilization. So mobilization of intervertebral joints, how will you do it? PA glide. See, this is your position. Can you see that? Can you see that, everybody? Are you able to see?
Yes, sir.
Yes, sir. Okay. Then superior glide. Nice. Okay. Make your thumb like this and do the superior glide. Okay. Just see that, and then we'll have discussion even further. Inferior glide. I can't go that side, so I'm showing you from this side. You can just see. I have to go on the caudal side of the patient. Okay. Then I have to superimpose thumb, and then it has to go like this. I can't go to the caudal side because of some issues. Wait, let me go. Yeah. In this case, you see, I'll go to the caudal side and I'll do this. What I said you, the inferior glide of costo-transverse joint. I have given in the list. You can see that. Costo-transverse joint. Okay. What is costo-transverse joint? Anybody? Okay, I understand you know that, but I just asked you. Okay, now mobilization of rib. Okay, mobilization of rib. In prone line, first we'll do. You see how we will do the mobilization of rib in the prone line. Okay, can see that? Everybody can see that? Like this also you can do. I always do like this, 90 degree. Okay, mobilization of rib. I'll go to this part and try to mobilize the rib. Same thing, we can do it in the sideline. Suppose he is having a good relax, and then here you can put some pillow between his legs and he'll be relaxed. And then in this case, we are doing the mobilization like this, superimposed thumb. Okay, each other. Cool. Now we are no more on the joint. We have come to the ribs. Okay. So this is how the difference is. Your method should be almost same, but the only thing is you are doing with the ribs now. Okay. Now, now let us talk about mobilization of rib in the supine line. Very simple. It's okay. It's okay. It's okay. You can just tell him to hold like this for this one, and then you try to take his mobilize like this, and then try to upward stretch. Upward stretch. See, it is like upward stretch. Everybody is understanding this? Upward stretch. So anterior, upward movement I'm going. You see, I have to go up like this. Now, suppose I have to do some more aggressiveness ribs in the modified supine line. What I'll do, I'll show you. I'll do like this. I'll hold this caudal. Not just cuffing techniques, Pooja, it is actually very important. Anyway, we'll discuss when it is important. Okay, don't worry. I've given the indications also. I think you can go through that. Mobilization of what we say facet joint. Now next we will see the mobilization of facet joint. Very simple. Take his caudal part like this. Okay, go like this. Suppose I have to do for this part, I will use this like a, how do you hold the, kind of gun, plastic gun. So same like this. Are you feeling better? Yeah. So then mobilization of facet joints with wedge. You can use some wedge also in between when you are doing the facet joint mobilization. So many people do with that also. And then there is something called mobilization of costovertebral joint. Okay, costovertebral joint is nothing. You have to take your hand. Suppose I am doing the T8 near that costovertebral joint, and then we are trying to lift up like this. We are mobilizing at junction of vertebra and ribs. Got my point? That is where we are trying to mobilizing with our fingers. So Yeah. So thanks. So everybody, you should say thanks to the model because he's almost done. He'll be leaving now.
Thank you everyone.
Thanks for coming.
Thank you, sir. Thank you so much.
Thank you. Yeah, it is very difficult to get like a kind of model in the COVID day, and he's my cousin. He's also a working person. Just 1 minute, I'll mute, and just 1 minute I'll. So so I would request CEO sir to give me permission to share the slides again, so that I can go to the slide and can see that if something is remaining, or Dr. Divakar is there. CEO sir. CEO sir. I think sir is busy. No problem. I will just see that. Is everybody ready with the this one? What we say that manual? Everybody is ready with the manual.
Yes, sir.
Yeah, I am checking out with the manual if something is like has to be. I have to ask or something. Just one sec. Just one sec. I'm checking out. Yeah, we have done gossiping, asif maneuver, belt exercises also we did, boutique also, AD also, PD also, cuffing technique, controlled. Now there is something called sprinting also we have done, controlled mobilization. Yeah, controlled mobilization and work simplification, that I will speak for about 5 minutes, then you will be able to. Yeah, in your manual I have given the postural drainage, and I apologize that the bed is not like this, and the model he has some issues with his back, so I did not utilize him in like taking different positions, but but this postural drainage, this one you go through this like what we say, the table, and then this table is one of the easiest table you will ever find for the postural drainage. I would edit the video and send to you for this also from my other class what I have shown on the postural drainage, and then you can correlate just like my studies when I was talking. You could have correlated to the manual the same way. You can correlate and you can learn. Okay, fine, it's upper lobe, apico-anterior, semi-flower position, how to do it likewise. Okay, I'll just forward you that video. Please remind me even later. So control mobilization and work simplification. Before that, somebody is whispering. Just a minute. I'm coming to your questions. Just a minute. I was just checking out whether anything is removed. Yeah. So work simplification is something, it is very important for those who have done the masters in neurology, can understand well, like for the like for SMA kids or for multiple sclerosis in later phases or subacute phases, we are using the long spoon. Okay, long spoon, or maybe in their bathroom Parkinson cases we are using a lot of handles. Why? Because we want to simplify the work. Suppose I'm having a, of course I'm like I'm saying you for the patient, so having a lot of weakness or rigidity, and he is restrictive lung disorder problem. Okay, so in that case you can't expect a person to move around in the bathroom or in the corridor easily, right? So in that case, always if you give him any kind of what we say, any sort of what we say that help that will decrease his dyspnea level or that will decrease his effort. So our, as a physio, as you should have always uh, you should always plan for reducing the work for the patient. So you manage in such a way that it is reduced. So this is something very, very important. I think one question had come in between, the rib springing, right? Rib springing is not in this PPT. You want me, then I will put it. That's not a problem, but actually when I prepared, I did not see this much. It's actually the rib springing is a kind of bit, like bit more exerting technique. Okay. And it actually bit more exerting technique, and it actually, what we say, of course, it increases the rate and depth of inspiration, it increases the lung volumes, everything. And it actually try to make the patient cough also many a times. So this is how the rib is springing. If you want, I will attach also. I don't have the video as such, but
Yes, sir.
if I don't have the video for the rib springing right now, I will
Dr.
try to
Saurav?
do. Yeah.
Yeah, you can share the screen.
Okay. Trying. No problem, sir. I was just checking out whether I have left anything around. So somebody asked me about the rib springing. That is something a bit more vigorous technique. So I did not include that in general. So okay, I'll send you this rib springing video. I'll perform on the very same model and at my home, and then I'll send you this. I think this is something, it's a bit more vigorous technique, nothing else. Okay, so in general, if you want to know about the rib springing, just try to understand that it is a kind of technique where it is a kind of technique. Just a minute, take me a gallery view. Yeah, it is a kind of technique where actually during the expiration, physical therapist has to have like overpressure at end of expiration, and compression. Then compression is then you have to just remove suddenly. That is how it happens. Like all of a sudden, if you remove this releasing of your thumb or the pressure point, I mean the pressure like superimposed thumb, so that increases the tendency of having a deep inspiration. That is how the deep inspiration is supposed to move your secretion also. So that is how like, suppose this is my rib. So what I do, I'll be pressing at expiration and then I'll remove all of a sudden. So that is how it will be spring up. That is how it is a springing kind of thing, and nothing much very special. But if you want, I will just put it a 2 minutes of video or this one PPT. If you want, I will get it done. That's not a problem. So anybody has any question can ask me. We have come to the almost end of the session. Anybody has any concept, understanding problem or anything, please let me know. You can unmute yourself and ask your doubt. I have sent the because I'll be showing you this a cappella and this what do you say, this flutter and all in the photo. Just and then I'll show you the position of this one also. Position of electrodes, what I was talking about, the tense and all, how to keep in the cardiopulmonary condition. Spirometry, every one of you have seen, so that's not a big problem. And somebody asked me about this panting kind of panting technique. I think I have explained in this, what we say this in the manual. So which part of panting has given you difficulty? Can I know that? Which part you feel that it is a bit tough to understand or something? Tell me, no problem. I can hear you. Look, I told you pacing and panting both. Okay, these are the volume as well as the what we say the flow based. Okay, so many a times it is a volume and flow based. So many a time it is a high flow, high velocity, and that sort of thing. So in case of panting, okay. So in this case, what happened in like a stressed expiratory exercises. In this case, even the manual I have written, you see, you can experiment on yourself. You can inhale to vital capacity. Okay, and then briefly exhale forcefully at high lung volume. Okay. Okay, so what happened here, high volume and high velocity concept you follow, so that it is, and the two you follow for several times. Say for example, 3-4 times if you follow, that's how it actually improve your secretion clearance. So what happened, you go to the vital capacity completely. I showed you from the patient perspective, but if you show from the patient, I mean the model perspective, it will be like this. Okay, patient generally will cough for this. So I told you this high velocity, high volume concept has to be followed in later part of your pulmonary rehabilitation, not in earlier part. So I showed you in the patient perspective first, then I'm showing you the model perspective. You know, briefly you have to exhale at high volume. Likewise. So this is how forceful exhalation it happens at this panting. Anything else? And those asked about panting is clear or else? Mahendran. Okay, thank you. So pump coughing also you asked. Okay. Pump coughing. Okay. Just tell me what kind of coughing it is. A pump coughing. What do you understand? It is a active coughing type, right? If you want, then I think in my manual I haven't described it. So I'll do one thing. I will try to describe two lines of kind of procedure that let it be a task to me, and then within few days I'll send to you on the group. I think the coughing is not explained generally because that depends upon patient to patient. If I explain the manual, they might try for this. So okay, I'll just explain you one by one, and then I'll type it down and send it to the group, the same group. Okay, so don't leave the group. It is important for you to know about this thing, and the other thing you'll be knowing about our upcoming events also. Okay. In this, what happened? You see, I'm patient. Okay. If I can lift up my arm, okay. If I'm having a bypass surgery and all not required, okay, for 3 months, then patient take a deep breath. Then he gives 3 short easy cough. Then what happened? He does 3 huffs also. Okay. Okay. Why it is important, you know? Many cases, if you remember from the earlier part of our class, I was talking about physiology of interdependence. So in emphysema, cases of emphysema, I mean the chronic cigarette smoker, in those cases, there is always a chance of air trap. Okay, so this is one of the beautiful thing, the pump cuffing, where you can remove the air trap from the patient. So somebody visiting to your clinic or hospital with the, you know, like a chronic emphysema case, please try pump cuffing. Pump cuffing is very good for those kind of people who has a like a history of air trapping. Okay, so what you have to do? You have to deep breathe, 3 cups, and after that 3 huffs. Yeah, I'm finished. Is it okay, Mahendran? Thank you. Anybody else? Otherwise, I'll start asking questions. You have any doubt, please ask. Otherwise, anyway, I have to start asking questions. I have to talk about some of the case history. Because always there is a confusion between double cuffing, controlled cuffing, pump cuffing. Now you can't say the controlled cuffing by a person having a like a phrenic nerve palsy, right? You can't say that. So we have to understand where we can use what. Most of the time, double cuffing and all is after this bypass surgery and all is fine. But controlled cuffing also okay, but you can't do to the neuromuscular disorders. So that is how our limitation is there. So I told you many types of cuffing exercise. Maybe in internet and other places or this one you can find even more. I'm not sure about it. But still this is something I wanted to give you the advanced techniques so that you can just have a good, data and you can have good data and so you have, if you have a good data, you will definitely be able to do better this one. So yeah, I'm almost at end. So please unmute yourself and ask questions. I have stopped sharing of documents. So now I'm in the gallery view. Please switch on your video, every one of you. I would like to see face of everyone. Because of the time scarcity, I could not introduce also yourself to me and me to yourself. So I'm taking here the camera. How can you keep the the electrodes in the thoracotomy? How you can keep the electrodes in the laparotomy? Okay, for your electrotherapy. Then I will show you something called the flutter. I have a book in that. Flutter is there. I think I have explained the equal point of pressure also quite well. But you are always welcome to ask me about the equal point of pressure and other things. I might be a bit delayed, but I'll give you the this one. I have a book in that, even that there is a flutter is there. You can see the flutter. So somebody is breathing in. This ball kind of thing is stuck in this, so that will create the kind of vibration as well as the resistance, right? That vibration, it will create the positive pressure inside the lung, and that is what is very much needed for excretion. For secretion of removal of secretion. So positive pressure we need to build up. There are something called a cappella also. A cappella and all you may not use more. And apart from that, we are I'll just take a photo and share you the electrode placement. So today you must have understood. Yeah, come on the video, everyone. So today you must have understood what is the value of X-ray in the pulmonary system. It's not just for the pulmonary cases. I'm telling you, as a cardiophysio, it's not just cardiophysio. It is important. It is important for everyone. Okay, not just lung, bones. So in the lung you see, and then see if you have a neuromuscular case, how will you come to know electrode placement? How will you come to know the what kind of like lung capacity is going through? So our upcoming course about radiology in physiotherapy is particularly very important by a very like what you say dynamic radiologist in the country. So hope you will get that link. If you find the link, it's there in my Facebook profile, my Facebook page, as well as my company's Facebook profile and page. You can just click and book. I'm sure that you, since you have joined this one, so you have definitely like what we say, you have definitely privileged to get some discount also on that course. That I would request personally to sir, if you can provide some discount because you have joined my course. So that much I can do for you. Yeah, anybody can come and ask any question on video. I'm there. Anyone on the group? Even, yeah, Pooja, please.
Sir, we have Flutter as well as Acapella. So there's one more device which is known as Cornet, I have heard. So if you have a picture, can you show?
Cornet right now I don't have picture. In fact, Acapella also I did not have. In my clinic there was a Flutter. Acapella still I don't have, but I'll show you the picture. That's not a big deal. That's not a big deal. I will show you that. Even the inspiratory threshold training, there is a ball kind of like a tube kind of apparatus is coming. That I will also show you. What happened? I don't want to share the particular YouTube link. Reason behind that, they would not have done, you know, like for the patient perspective. The reason behind that. So once you are acquiring knowledge, your knowledge should be correct. So considering that. But still I can share you those things. And then when you join my like physical workshop, in the physical workshop, we'll detail more about the devices, more about like, you know, you can have hands-on training. And those who have joined my webinar, I mean, there are more than hundreds of students who joined this pandemic to me. So everybody, they will get definitely a big discount on that because I want them to have a hands-on training also. So let us see when the government allows, we will be catching each other.
So, and one more question. Which spirometer do you suggest? The tri-flow one or with single ball or which one?
Look, when it is coming to the spirometer, it all depends upon the ball, the weight of the ball. Okay. I personally prefer the tri-ball spirometry. There may be more than 100 tri-ball spirometry in my clinic. I always keep and, you know, like I give the gift to as a gift to the patient. Reason behind, I feel in that you have a better visual feedback. Okay. I mean to say, if you clearly, I mean, if you see it very closely, there is something 600 cc per second, 900 cc per second, 1200 cc per second. So you can make your patient, including the kid also, look, you are able to do now the red one, now even the green one, now you are able to lift up the blue one. So it is having a better visual feedback. And if you know the correct matter, what I told you today, the sustained maximal respiration, sorry, inspiration, that is, spirometer is based on that. So if you can tease them correctly, tri-ball spirometry is always good. No doubt about it. No doubt about it. But again, the single ball spirometry, there is nothing wrong. There is a ball weight, which actually goes according to your inspiratory holding capacity and the kind of flow you can. So definitely that also is good, no doubt. But in my opinion, if you have asked me, I always prefer that tri-ball spirometry anytime. Why?
Okay,
Did you
thank you, sir.
Did you find any difference? Did you find any difference in single and tri-ball?
Sir, actually, which I found is that while using the 3-ball, it's much easier because it can be used for the expiration also. So it is much easier for use of both the patients instead of just going for one ball spiro.
Exactly. Exactly. This is the reason, like it can be used for the what we say blow, and the blow
Yes.
is something very important. What we say the PFR. I told you that graph, no? That graph
Mm-hmm.
maybe we'll have one more class. That class is for 1 hour. There we are shifting like how COPD and obstructive lung disorder goes to the left corner, and then restrictive lung disorder goes to the right corner. Because I know that kind of the amount of information I gave you, that is generally to be covered in 15-20 days. It's not so easy to cover in 4 or 5 hours. So especially the initially for 2 hours, whatever we discussed, the advanced what we say advanced concept of FRC, concept of intrapulmonary pressure, concept of compliance, concept of chest wall mobility, those concepts, it takes time to understand. So we will definitely have class on that, and then you'll get invitation that might be free also. So please join and share it, no problem. Fine. If you don't have any question, then you are most welcome to put questions on group anytime. Let us finish then. With your permission, see you, sir. Can I wind up?
Thank you, sir. Thank you, Saurav, sir. Over to Dr. Divakar.
Yeah, fine.
Thank you so much, Dr. Saurav. So nice interactive class, and all participants also so nicely they asked questions. And hope we'll meet you soon in the physical workshops. Okay. Thank
Sure.
you. Yeah. Thank you.
Thank you, sir. Thanks a lot.
Thanks, everyone.